Good morning, ladies and gentlemen. On behalf of the College of Medical Administrators, it's with utmost pleasure to welcome you all to this humble abode for the 30th annual academic session of the college.
Distinguished guests, esteemed colleagues, ladies and gentlemen, we are gathered here for the pre-Congress session 2023 with an apt and felicitous theme, which goes to say, health system resilience and sustainable financing.
As we gather here today, we come together as a community of individuals passionately committed to the pursuit of the knowledge, innovation, and advancement in our respective fields. This session has been designed to provide you with insights and tools to excel in your roles as leaders in the healthcare industry.
Ladies and gentlemen, it is customary in this part of the world to invoke the blessings of an age-old tradition into any noble occasion with the lighting of the oil lamp.
This cherished custom symbolizes the enlightenment of our hearts and thoughts, marking the beginning of the occasion rich with light, wisdom, and unity.
We are greatly honored to stand in front of you today to commence this special event with the brilliance and purity of light from the traditional oil lamp. We would invite the following dignitaries to do the honors.
Firstly, Dr. Krishna Reddy Nallamala, Regional Director, Access Health International, Asia.
Who will be followed by Professor Nalin Abesekara, Professor in Management Studies, Faculty of Management Studies, Open University of Sri Lanka, and also by Professor Tan Hiang Hoon, Deputy Chief Executive Officer of Future Health Systems, Singapore General Hospital. And also by Mrs. Vijaya Rao, Director, Sing Health, Singapore.
Dr. Asela Gunawardana, Director General of Health Services, and the immediate past President of the College of Medical Administrators. Dr. Lal Panapitia, President of the College of Medical Administrators, and the Deputy Director General of Health Medical Services 1.
And we are also honored to invite Dr. Samidhi Samarakon, Secretary of the College of Medical Administrators and Deputy Director General of Health Services, Education, Training and Research, and also Dr. Sudat Dharmaratna, Chairperson, Academic Committee of the College of Medical Administrators and Deputy Director General of Health Laboratory Services.
And we also cordially invite Dr. Sadasivam Sridharan, the Deputy Director General of Health Services, Planning, and the Chairperson of the IT and Media Committee of the College of Medical Administrators. And we also kindly invite our past presidents, Dr. Neelamani and Rani Fernando. Dr. Rani Fernando, madam, please join us.
We'll also call upon Dr. Kapila Vikramanayaka, our treasurer, the treasurer of the College of Medical Administrators, to join us.
Thank you. Ladies and gentlemen, following that brief ceremonial outset, it's now time for us to begin the program laid out for today. Thank you, ladies and gentlemen. Following that brief ceremonial outset, it's now time for us to begin the program laid out for today.
To begin the proceedings, first and foremost, to formally commence today's program, we cordially invite the President of the College of Medical Administrators, Dr. Lal Panapitia, to make the opening remarks and welcome this distinguished gathering. Over to you, sir.
Very good morning to all of you. Today our special guest, Dr. Alaka Singh, the country representative of the WHO, she will be attending soon. So then I would like to actually convey our welcome to Dr. Alaka Singh also. And Dr. Asela Gunawardena, Director General of Health Services and Chair of the session this morning today, and Dr. Mrs. Vijaya Rao, Director Singh Health, and our guest speakers and panelists for the sessions, Dr. Krishna Reddy, Regional Director, South Asia Access Health International, Professor Nalina Besekara, Professor in Management Studies, Faculty of Management Studies, Open University of Colombo. Dr. Sundarajan Gopalan, Senior Specialist in Public Health, Lead Consultant in World Bank Group and also WHO. Professor Tang Hiang Kun, Deputy Chief Executive Officer, Singapore General Hospital. The moderator of the sessions today, Dr. S. Sridharan, Deputy Director General Planning, and Academic Chair, Dr. Sudha Dharmaratna, Deputy Director General Laboratory Services, all other Deputy Director Generals, Directors of Ministry of Health, Provincial Directors of Health Services, Regional Directors, Medical Superintendents of Provincial Health Authorities, representatives from development partners, our seniors, past presidents, and college members, secretary, treasurer, and all my council members. Ladies and gentlemen, a warm welcome to all of you for the pre-congress session of the 30th Annual Scientific Sessions of College of Medical Administrators of Sri Lanka. It's truly an honor to stand before you to announce this session with a topic of paramount importance to the healthcare industry today, health system resilience. This council has completed nearly 10 weekly sessions during last 2 months based on the topics focusing on each strategies for a health system, for a resilient health system, which is the theme of the college for this year, rising through challenges, leading towards resilience health system beyond boundaries, leading towards health system resilience beyond boundaries. These sensitizing sessions were not only for awareness, but also for strengthening leadership of our members and motivating of them. And also, in addition to the other activities for each and every strategies. And today, our main pre-congress session has been focused on health system resilience through sustainable health financing and good governance. Everyone has the opportunity to exchange their thoughts with eminent speakers and clarify your queries with the expert panelists on various subjects going to be discussed today. Before we look into the discussions, I want to acknowledge this is a timely and highly important issue in current context, in this challenging time of economic crisis, followed by COVID pandemic, though as we all know, it was successfully managed with least effect to the COVID patients and also to the other patients. The economic challenges we face have added an additional layer of complexity to our healthcare system, resilience and sustainability. In these unprecedented times, the world has been reminded not only to the fragility of health systems, but also the interconnectedness of health and economy. Today, we embark on a journey to explore how we can build and sustain such systems, bearing in mind the economic challenges of our nation, our country. The COVID pandemic provided an opportunity to us to identify the gaps in our system. It has emphasized the need of developing the resilient health systems, which can withstand unexpected shocks, while continuing the essential health services, essential care for the patients. But health service of the country, as we all know, was able to withstand and manage the services successfully, not only in COVID pandemic, but also during the other recent crisis situations such as civil war and tsunami and etc. Proving the resilience nature of our health system. Dear council members, college members and distinguished invitees, it's all of our privilege to listen from our eminent speakers today with their unmatched knowledge and experience in the light of health system resilience in times of economic uncertainty, sustainable financing in a struggling economy, looking into the role of good governance, envision the future of regional health. Since your collective wisdom and collaboration are instrumental as we confront the challenges what we are facing. I encourage you to actively participate and engage in discussions. In closing, let me extend my heartfelt gratitude to all the distinguished speakers and panelists in accepting our invitations to share their knowledge and experience with us. And also to the organizers, especially Dr. Sridharan, Academic Committee, Dr. Sridharan, moderator of the session today, and Academic Committee Chair, Dr. Sudha Dharmaratna, Dr. Samantha, Dr. Upuli, Dr. Nalin, if I have missed any names, so then forgive me, and all who actually contributed to make this success, and all our sponsors, and not only that, actually, also to all the participants today who are participating today, who have made this pre-congress session possible a success. Thank you, and I wish you all fruitful and enriching session ahead. Thank you.
Thank you, sir, for sharing your valid thoughts with us. You have truly set the perfect tone for the event with your self-assurance and passion.
Well, following that brief but vital formalities, it is now time for us to move on to the focus of today's event. We have 4 lectures lined up in the schedule, followed by a panel discussion. Ladies and gentlemen, on this note, we would like to invite the following dignitaries to grace us at the head table. Firstly, as the chairperson, we'd like to invite Dr. Asela Gunadana, Director General of Health Services and immediate past President of the College of Medical Administrators, followed by Dr. Lal Panapitia, President of the College of Medical Administrators and Deputy Director General of Health Services, MS1.
And also we kindly invite the moderator of the proceedings at the head table. We are honored to invite Dr. Sadasivam Sridharan, Deputy Director General of Health Services Planning, and Dr. Sudha Dharmaratna, Chairperson, Academic Committee of the College of Medical Administrators and the Deputy Director General of Health Laboratory Services.
Joining us at the head table would also be the distinguished panelists for today's technical session. We are honored to invite the following dignitaries to join the head table.
Dr. Krishna Reddy Nallamalai, the President, Access Health International, Asia, as the first guest speaker.
Professor Nalin Abesekar, Professor in Management Studies, Faculty of Management Studies, Open University of Sri Lanka, as our second guest speaker. Followed by Professor Tan Hiang Hoon, Deputy Chief Executive Officer of Future Health Systems, Singapore General Hospital, who would be our third guest speaker. who would join us later. And also, joining us on a virtual platform would be our fourth guest speaker, Dr. Sundara Rajan Gopalan, Senior Specialist in Public Health and Lead Consultant, World Bank Group.
Ladies and gentlemen, before we commence the proceeding at the head table, please let me introduce our moderator for this session. Dr. Sadasivam Sridharan, a consultant in medical administration, has been the Deputy Director General of Health Services Planning of the Ministry of Health since 2017. With an eminent academic background, he holds master's and doctoral degrees in medical administration, a Commonwealth Executive Master's in Business Administration, and postgraduate diplomas in healthcare management and total quality management. Notably, Dr. Sridharan pioneered the first hospital quality management unit in Sri Lanka and was instrumental in Mahayangana Base Hospital's achievement of the National Productivity Award and Taiki Akimoto Award in 2005. As the founding director of Healthcare Quality and Safety, he championed the ministry's apex body for healthcare quality and safety, established in 2012. His international repute is recognized by his tenure as an honorary clinical governance fellow at the Sherwood Forest Hospital's NHS Foundation Trust, and his contributions to Asia Pacific Observatory on Health Systems and Policies. A distinguished researcher, teacher, and board member of the Postgraduate Institute of Medicine, Dr. Sridharan's contributions are globally recognized. Sir, we may have the honor of handing over the microphone to you to moderate the proceedings at the head table.
Thank you and good morning to you all. Protocol observed. I must thank, first of all, College of Medical Administrators and Academic Committee of the College of Medical Administration to select sustainable health financing as the pre-Congress session agenda, because health financing is a core function of health systems that can enable progress towards universal health coverage by improving effective service coverage and financial protection. Healthcare face globally, first, growing cost pressures with population aging. Second, new technologies and consumer expectations around healthcare coverage and quality of care provided. And Sri Lanka, at present, we are facing 3 Ds: debt, devaluation, and new diseases. So if you take a global health, why this is important? If you take the global health spending was 3.2 trillion US dollars, about 10% of global gross domestic product. Only some 12% of that, that is about $350 million, was spent in low and middle income countries. Globally, there exists an enormous mismatch between countries' health financing needs and their current health spending. Developing countries account for 84% of the global population and 90% of the global diseases burden, but only 12% of global health spending. So 3 key important policy relevant questions for health financing are: how much should we spend on healthcare? What level of coverage we provide, and how do we increase value from existing health system resources? I hope today's session will answer a few of these questions. With that introduction, first of all, I would like to invite Dr. Krishna Reddy Nallamalla, President, Access Health International Asia. He will be addressing on health system resilience, understanding, and the concept. So, Dr. Krishna Reddy Nallamalla is the President, Access Health International Asia. He is building in order the Health Systems Institute with the purpose to strengthen systems to secure health. He is the program lead for Global Learning Collaborative for Health System Resilience and Digital Health for Universal Health Coverage. Access Health undertakes research to inform health policy, offers courses in building human resource capacity and health insurance management, health information management, and health leadership and management, provides advisory and ample technical support to national and state governments and private sector stakeholders. He is a leading cardiologist and co-founded Care Hospitals, a large hospital chain with presence of 6 states. He founded the healthcare service group that is currently evolving into the model healthcare service provider under the banner of Trust Healthcare. He was responsible for development of India's first cardiac stent. He founded Relicis Medical Devices and IncuMed to carry forward the legacy of self-reliance in advanced medical technologies. He is on the board of trustees of US Pharmacopoeia. Over to Dr. Krishna Reddy.
Thanks for that introduction. Dignitaries on the dais, all the senior administrators in the audience, the visitors from other countries. I must confess that I may not be the right person to discourse on this complex subject of resilience. But my job is to convey whatever the learnings that we are getting on the subject of resilience through a collaborative learning effort. In fact, in the last 1.5 years, we have brought together policymakers, academicians, the practitioners, the civil society, the United Nations agencies to have a dialogue around this concept of resilience, which is new to the health systems. Resilience was originally applied to the physical substances in terms of their elasticity when you apply stress. But subsequently, it came into the being for other social systems and the economic systems, that when there is a crisis, when there is a shock, when there is a stretch and strain on systems, whether the systems are designed to absorb those crises and recover from the crisis in a very stronger fashion. So this is basically a broad understanding of what is resilience. I quickly take through, most of these systems approach all you are aware of. But what begins is the people's health. And what are the determinants of the people's health? And also, what are the threats to people's health? Because these are the two things that determines most of the people's health. Because when we say health systems, they are evolving to respond to the people's health needs. So any discourse on resilience should start in the context of what is the health status of the people in terms of the disease burden, in terms of the longevity, in terms of the mortality, morbidity, but more importantly, what are the health needs of the people, and whether the health system is responding to the health needs of the people. When we say health needs of the people, when they want, what they want, where they want, and how they want. I think that is what the people-centered health systems are supposed to do that. It is not top-down, but are we responding enough to the dynamic needs of people? And these needs are not static. They are changing. They're changing every year. And within a year, it can be changing during a endemic season, or it may be a crisis like what we all witnessed in the last 3 years, the COVID crisis, Ebola crisis, the SARS crisis, the Nipah crisis. We are only familiar with the biological crisis, but we are also realizing that health also is impacted by other crises. I think Sri Lanka is an example of economic crisis. Pakistan was an example of the climate change with flooding. I mean, never heard of flooding, which Pakistan is going through that. The geopolitical conflict the world is witnessing across many regions, Africa, the Middle East, and now in Europe. So all these threats, I mean, I think that's what the resilience is when the system tries to understand what are the threats the population faces in a given country or a given region. Because each country has a different threat. I mean, island nation like Sri Lanka may have a more threat from the climate change, or landlocked nation may have a more threat from the geopolitical conflicts. So it has to be contextualized to a given system. It may be at district level, it may be at state level, it may be at national level, it may be regional level, or even a global level. So the issues are different at different levels. This is to clearly understand the health system, how it has to respond to these needs. I mean, most of the definitions of the WHO and other things, we confine to the system response, that you are responsive to the health needs, and also you don't want the financial hardship to the people in accessing the health needs in a universal basis. That means all people should access health at all times. We did not include that word at all times. When you say at all times, that means during the normal times and during the crisis times. So the definition of a health system, the normally functioning definition of health system, has to be slightly reconfigured to include that it has to be responsive at all times. As a cardiologist, if I take a heart example, normally it pumps about 5 liters of blood. But if you have to sprint because the tiger is attacking you, your heart can pump 30 liters per minute. That means the 6 times the demand it can easily meet. So it is resilient. The heart is designed to be resilient to meet 6 times the need from the normal times. That exactly is the word for health systems resilience. That means, suppose in the COVID times, at the peak level of infection, at least in India, there was a 20 times increase in oxygen consumption. So whether the system was geared to meet that surge in the demand. So ultimately, it is the demand and supply. Today, you may be strong. You may be able to meet all the demands of the people. But when there is a crisis, when there is a sudden surge in the demand, or there may be disruption in the supply. During the COVID, we saw that. I mean, you have lockdowns. The health workers were down with COVID, and people were not able to supply the medicines and the diagnostic tests. So it was a combination of surge in the demand, and also there was disruption to the supply of healthcare services. So this is, in principle, that means the system were not designed or not assessed whether they are prepared to face a crisis. There was no modeling. There was no simulation modeling as to whether the system is able to face the crisis. So that is the learning that we had from the COVID, that it is not enough to say that I have 1 doctor per 1,000 or 1 bed per 1,000 or 3 nurses per 1,000 population. We have to see whether in a given village, given district or given taluk, whether there is enough healthcare supply in the form of beds, in the form of human resources, in the form of drugs, in the form of diagnostics. If that is not designed, that means it is not equitable. That means all people don't have that equal opportunity to access the health care of decent quality that they require without financial hardship. So I think these are, once this understanding is there, then the resilience becomes easy to understand in terms of how you prevent crisis, then how you actually respond to the crisis. This is a classic description of a health shock. When you have a shock, there is a disruption. There is a disruption, and then you start absorbing that shock, and some systems may not recover from the shock. Some systems may be able to recover from the shock. And some systems recover from the shock to the original weak state. I mean, they collapsed because they were not strong enough. So idea is when they recover, a resilient system, when it recovers to a better system. I mean, you might be hearing the words from the Director General of WHO, the building back better systems. It is not just you don't go back to the previous system. You have to build a better system when it collapses. So that is the whole example of this diagrammatic representation of a resilient health systems in response to a shock. So that means it should be able to absorb. Even if the demand is 3 times, if the demand is 4 times, it should be able to absorb. But to absorb that, do you have that excess capacity? And for example, on one side we say that we have to be efficient, our bed occupancy should be 80%, our throughput should be that much. But when you are operating at 80% efficiency, which is required, I mean, you have to be efficient because you have to be financially sustainable. But at the same time, when there is a demand, and when you don't have reserve capacity, what do you do that? So these are some of the thought processes as to how to prepare a health system to be resilient. That means it's able to absorb the sudden surge in the demand or disruption in the supply or combination of both without disrupting the essential health services. That is a part of the resilience definition. You are able to meet the needs during the crisis, absorb the shock, but without disrupting the essential health services. So these are the 3-4 elements of the definition of the health system's resilience. I mean, how do you characterize them? So given this definition, that means we are slightly shifting our thought process. One is that health systems should perform during the normal times and during crisis times. The second is the health crisis does not mean only an epidemic crisis or biological crisis. It is an economic crisis, can be the same thing. It can be a climate change crisis, or it can be a geopolitical conflict, or it can be a mass migration of people. We are witnessing, the world is witnessing all these crises, the confluence of crises. We don't require any examples for that. So that means we need to expand the definition of health in terms of not just the human health, but it's the animal health, plant health, and planet health. It is not just the living beings, but the non-living also. So unless the whole system is healthy, the human beings are not healthy. I think that. And within the human beings, unless everyone is healthy, no one is safe. So I think that realization happened during the COVID, that I'm rich, so I'm healthy, I can access everything. It does not happen like that. I mean, if your neighbor is not healthy, you are equally at risk. So that realization of one health concept, the whole of systems concept, the whole of governance concept, I mean, these are the evolved concepts in the context of the COVID and in the context of the definition of resilience. So when we have evolved this concept beyond the conventional 6 building blocks model of the WHO, because that was designed only to assess whether your health system is strong enough. But it is not complete. It's not complete. It's strong enough in terms of you're able to meet, because you have 1 doctor per 1,000 people, you're able to meet the needs of the people. But you haven't thought of whether this 1 doctor per 1,000 is sufficient when there is a crisis. If it is not sufficient, then what are the innovative methods of planning, preparing the system to face this system? So this is a conceptual model that we have been evolving in the last 1.5 years through the collaborative discussions, as I said, among the various stakeholders. So so here, if you look at, it starts with the individual in the center. So it brings it to the focus that individual, it starts with the individual. Individual also can be resilient. How people are actually preparing for the crisis. People can prepare. How do you make individuals resilient, families resilient, communities resilient? So that is one level of resilience, building resilience in the community. Then you take it to the local governance level, take it to the district level, take it to the subnational level, the national level, and the global level. The issues are different. Say, if you're looking at the global issues, it is the transnational issues. That means the health regulations, the data sharing, the goods sharing, the people movement across the borders. So those are the different issues in terms of the global level issues, whether it's the financing, whether it is provisioning, whether it's supplying, or the governing. Similarly, at a national level, the issues are different. The subnational level issues are different. The local level are issues different. But the functions at different levels are same and can be looked at. I mean, you look at the four core functions. Important function starts with the provisioning of care, whatever needed care. Then the next is supply of the needed drugs and the diagnostics and the devices. The third is the financing to access this health care and also the provide health care. Both. You need finances to provide and finances for the people to access. I mean, so both ways you need financing. And then, more importantly, how you govern this entire complex system. I mean, these are the four core functions everyone is familiar. More focus was on only provisioning and financing. Less focus was on governance. We included governance as part of the 6 building blocks, but we never defined what exactly is the governance. And in COVID, that was a key lesson that the countries with good governance systems performed much better. So a lot of blame was, even if, like US, it was a health security index, it was the top, number 1. But in terms of the performance, it was not number 1. It was in the bottom, in the OECD countries. So that means your assessment, the existing assessment systems of health system security assessment, health system strength assessment, there are deficiencies in the current assessment systems. So that is the reason why we need to evolve with different assessment systems. So these are the 4 functions that we emphasize on in how these functions are essential to respond to the people's health needs. But what is, and similarly in the governance side, I mean, we think government is equivalent to the governance. It is not. Governance is the 3 actors: the people, the public sector, the private sector. And each of these actors have their rights, their responsibilities, and their accountabilities differently. I mean, so each one is a complementary. It is not just one is totally responsible for it. So this has to be understood differently. And the governance, how you actually build the governance, what are the institutional mechanisms of interaction between these various actors of the governance. We always say community engagement, we always say private sector engagement, but where is the institutional mechanism to engage? Are there any health councils where the people, civil society is involved in decision making? So there is a area for each one of you to explore what is this triangle of governance. Another triangle of governance is providers, the payers, and the people. Again, that is an important triangle of governance. So we introduced this conceptual framework of triangle of governance into the health systems framework. Then when you look at this diagram, it is basically expanding into the rest of the, so this is to illustrate a One Health concept. So you'd see the planet actually behind, in the background. That means you are looking at from people health to planet health. And you see those intersecting wavy forms, which are the most important functions, which we never give importance. That is information, communication, and relations. So these 3 functions are the cross-cutting functions. The health systems and the social systems are so complex, so fragmented. They are interdependent, they are interconnected, they are dynamic, they are open. I mean, this is the systems concept of any social systems or the health systems. So unless we have a similar emphasis on strengthening these cross functions of information, communications, and the relations, like the center-state relationship, the public-private relationship, the international relationship, okay, the people and the policymaker relationship. Where are the institutional mechanisms for these relationships? Why we haven't given importance to that? Because these are the three things which actually make the systems harmonious. Otherwise, they will be dysfunctional. So this conceptual framework, we try to bring in equal emphasis on those four core functions and these three cross-cutting interlinking functions. So we say this is a 1+4+3 model. That means people in the center, then four core functions to respond to the people's health requirements and the financial requirements, and the three cross-cutting functions to integrate the complex health systems and harmonize its function. Then it becomes resilient. So these are, I think, I wanted to introduce this evolving conceptual framework of health system in the context of resilience. I will try to summarize 2-3 slides because any system, especially as an administrators and the managers of health systems, just like a doctor, I mean, we first say clinical assessment, right? Then we say diagnostic assessment. Then we say management plan. Then you administer the treatment plan, and then you follow up whether it is working or not working. Same way, if you look at health systems as a patient, then you have to first assess what is the status of the health system. Is it strong enough? Is it secure enough? Is it resilient enough? But what are the indicators for that? I mean, which tools you use to assess in every year fashion? Because you have to keep on assessing. Like you have assessed the baseline assessment of these three parameters. What is the strength? What is the security? And what is the resilience? Then once you do that assessment, just like the clinical assessment, you diagnose what are the problems. What is the pathology underlying these diseases? Is it corruption? Is it poverty? Is it lack of self-reliance in manufacturing drugs? What exactly is your pathology? What are the gaps? Is it lack of resources, health workforce resources? So this assessment is the most important thing, which this collaborative, the learning collaborative, we are trying to evolve and actually test as a pilot. In fact, as a part of the Global Learning Collaborative, we are going to formally launch Sri Lanka chapter this month. So that, because each country we are trying to assess as a pilots, like India is one chapter, Indonesia we already opening the chapter, Bangladesh we opened the chapter. So each country will learn from each other because the context is different. I mean, how each country is responding, is it applicable to other countries? So it's a kind of a cross-learning among the countries, among the stakeholders, because policymakers, what lessons they have. So this is what we are looking at. This has to be assessed, as I mentioned. Always never forget the people's context. I mean, what exactly is their health status? Do we have the health status? I mean, nowadays, only people download from the International Health Institute for Monitoring and Evaluation, IHME in Seattle. But countries have started forgetting that they need to have their continuous monitoring of what is the disease burden of their population. What is the prevalence of the disease? So then only you can understand what will be the health needs. Once you have the health needs assessment, then you know what is the health demand assessment, and according to the demand, you have to provide the supply of the systems. So this is the starting point. If we don't have that assessment in the context of the people, so some of the assessment tools are already there in terms of the health system strengthening assessment using the WHO building blocks with modification by each country. Then you have the health security index, again globally in terms of, especially after the Ebola, you have the joint external evaluation for the health security index. Each country has to be self-monitoring as well as external monitoring, whether they are secure enough in terms of their surveillance systems, response systems, and alert systems. Similarly, the resilience health systems should have a robust assessment. So I'm not going to detail into what are the indicators of resilience because this is an evolving subject. I think once the Sri Lanka chapter opens and we do the pilot of Sri Lanka's health system, and then we will reconvene similar meeting maybe by next year, that what are the indicators of resilience of Sri Lanka, which can be to say whether this country is resilient or not. For example, if there is a 6 times increase in the demand, do you have a modeling? I mean, do you have a currently dynamic data as to what are the number of beds you have in this district? What are the number of doctors you have in this, both public and private sector? Don't just only look at the public sector. As a health system, look at the whole system. How many nurses are there in the whole system? Then what is the current capacity utilization? What is the bed occupancy on a dynamic basis? I mean, the system can get every day what is the bed occupancy of each hospital. That means in a district, how much capacity you have on a given day. And if there is a surge because of Ebola or dengue or something else, you can pool these resources. You can pool these resources, and that means you can have a prior agreement, preparedness agreement with the private sector that when there is a crisis, we will be pooling that, and we will be paying you for pooling these resources. So that is the interaction between the public and the private. I mean, some of those I'm just giving as an example of how to actually build a resilient health system in a proactive, preventive, and preparedness way, not just absorption way, but how to prepare the system. So these are, I think, some of the principles, as I mentioned. We will be looking at the people's aspect of it. Then we will be looking at the 4 core functions and the sub-functions of those 4 functions, and those 3 cross-cutting, interlinking functions and their sub-functions. And then assess a health system in the context of these things during a pre-shock, a preventive phase, preparedness phase, during shock phase, the recovery phase, and building back better through a learning process. So these are the 5 phases of health shock cycle, and these are the 7 functions of the health system. So these are the guiding principles of the health system. So just to summarize my introduction to the health systems, I hope this conceptual framework is easy to understand. And again, look at always from the patients whether the system is responding, whether the system is responding to the patient requirement. I mean, today, patients want the diagnostic sampling has to be done at home. And already a lot of systems, the private systems, are responding to that. They want a doctor anytime. Already the online platforms, the aggregator platforms are able to provide a doctor's consultation on time. So these are some of the things just I leave behind because there are rich presentations in the subsequent sessions on the different aspects of this resilience, whether it's financing, whether it is supply of medical goods, the health workforce. I think interesting discussion, but happy to take any questions later. I think if, whenever the questions are going to be asked. And again, thanks for this opportunity, and I hope to interact with the Sri Lanka's health system as a part of the Global Learning Collaborative. In fact, I'm coming back again as a part of the WHO CRO Primary Healthcare Forum from 16th and 18th. There also we are looking at how to design the primary healthcare, one from a normal times perspective, but more importantly, how the primary health care should become the core of a resilient health system. So I think this dialogue will continue. Thanks again. I think I realized that neighboring country, this is my first visit to Sri Lanka. Thank you.
Thank you, Dr. Krishna Reddy, for highlighting on health system resilience and how resilience can take place from individual level to global level, and how to proactively look into the health system resilience also. And with that, next I'd like to invite Professor Nalin Abesekara. Professor Nalin Abesekara is attached to the Department of Marketing Management, Faculty of Management Studies of the Open University of Sri Lanka. Professor Abesekara is currently serving as the Dean of the Faculty of Management Studies of the Open University of Sri Lanka. He is a graduate of the University of Sri Jayawardhanapura with BSc Marketing Special. Professor Abesekara is a chartered marketeer, fellow, a member of the Chartered Institute of Marketing, and consultant with over 20 years of experience. Professor Abesekara is serving as a visiting lecturer for PhD, DBA and MBA for degree program for leading national and international universities based in Sri Lanka. In 2018, Professor Abeysekara was awarded Outstanding Asian Educator by the International Association of Scholarly Publishers, Editors, Reviewers. Professor Nalin Abeysekara is the Editor-in-Chief of the Sri Lanka Journal of Management Studies and co-author of many international journal study articles, conference papers, and books. Furthermore, he is serving as the reviewer for many international journals, including the Journal of Services Marketing, Journal of Consumer Behavior, Journal of Management Development, Journal of Applied Research in Higher Education, and the International Review of Research in Open and Distributed Learning. He received the Best Reviewer Award awarded by the International Journal in Contemporary Management Research in 2010, Excellence in Research in Australia. Professor Abeysekara is the recipient of 3 gold medals in Strategic Management, Marketing Management, and Dissertation for his performance in his master's degree from the University of Colombo, Sri Lanka. He completed his PhD in the year of 2013 in Leadership in Marketing. Professor Abeysekara, in his attempt to socialize knowledge, has contributed many articles to leading magazines and newspapers in Sri Lanka on current issues covering economics, education, and tourism. Professor Abeysekara is serving as supervisor for PhD and DBA students in management and marketing. Professor Abeysekara will be speaking on role of good governance in building a resilient health system. Over to you, Professor.
Hi, Bhavan. Very good morning. All the dignitaries in the head table and college and the council members. I think Dr. Krishna discussed about the resilient health system in Sri Lankan context. So we are going to have a kind of alignment between the good governance in building a resilient health system. So as a researcher, I think I asked about the word of good governance among different stakeholders in the country. So 60 to 70% of the people, they say the good governance is a kind of a duty only vested for the government. But what we need to understand, we will have a discussion on good governance not only belongs to the government, it belongs to the institution, it belongs to the citizens of the country as well. So with that note, we will start our discussion. So what is this good governance? So how we define the good governance? So in studies and all, we are always asking about the operational definition with the indicators and measurements. Where it says the good governance, we are talking about legitimate, accountable, and effective ways of obtaining and using public power and resources in the pursuit of widely accepted social goals. By looking at this definition, we need to be very concerned about 3 different indicators. It should be legitimate, accountable, and effective. Now IMF mainly talking about 2 different things, the corruption and the efficiency. So here also in good governance, we need to be very concerned about these indicators and how you obtain and use the public resources, right? Power and resources. So these are the areas we have to be very concerned about. Then United Nations Economic and Social Commission for Asia and Pacific, so there is a very nice way they depicted good governance. Now we have to think, okay, now as an institution, as a ministry, even as individuals, what sort of variables we are going to take into consideration for this operationalization? Accountability, transparency, responsiveness, consensus-oriented, participatory, follows the rule of law, that is really important, and effective and efficient. In management we say, efficiency is all about input-output ratio. Effectiveness is achieving objectives. So whether we are very efficient, maybe in public procurement, so in the media we can see different news, so whether the effectiveness been achieved, so everything comes under the good governance. Then by looking at the context, what is the good governance in the context of health? Because now we had already discussed, had a kind of a definition in common. But here, the World Health Organization measuring transparency in the public pharmaceutical sector, so where we have very interesting definition. Formulation and implementation of appropriate policies and procedures that ensure effective and efficient and ethical management of all aspects of health system in a manner that is transparent, accountable, follow the rule of law and minimize corruption. Now we come to a very interesting point where not only we discuss about this general terms like efficiency, effectiveness, so ethics also there. Then again corruption factor also take into consideration. So then we need to have a reflection, not just by looking at the institution, by looking at maybe our council members, the college members, what sort of ethical responsibility vested for us, because we need to repay whatever the things we gain from the free education. I think Dr. C.W.W. Kannangara in 1940s, actually because of him only in Sri Lanka, the free education existing. Dr. C.W.W. Kannangara we considered as one of the very important scholar and important practitioner in the country. Most of the countries other than Sri Lanka, there are many PhD theses being written on the free education movement of Dr. C.W.W. Kannangara, not in Sri Lanka. Anyway, that also we need to understand. So this accountability factor, we should have our own reflections as the professionals as well. So that is really important. Then we are talking about the good governance in the context of health. So ultimately, yesterday night I had a Google search. Just put in health sector in Sri Lanka, but recent studies and all. So here we can see Transparency International integrating government hospital in Sri Lanka. Then they are talking about the particular corruption, then again bribery and all. So it means technically the GMO blames for that corruption for health sector, public health sector corruption in Sri Lanka. Then like issues of alleged mismanagement, irregularities and corruption in the procurement of medicine. So it means technically in Sri Lanka we already won the war against COVID. All the people, they have a respect for the health sector. That is there with the general public. But if you come for this sort of good governance, then again we need to have some sort of a reflection of ourselves, what sort of indicators and measurements we have to take into consideration. Because I am not telling this newspaper, because you need to understand, some are just reporting. Journalism cannot be seen. Journalist is different from reporting. But from our side, if something been reported for the general public, there should be a way to correct, unless it has been established in people's mind in a different way. That's why in marketing we are talking about something called public relation. Public relation is really utmost important for the health sector, because unfortunately the newspapers, they had a very large heading allocating half a page for whatever the thing, and ultimately we send the clarification, they put a small thing. People don't take the notice. So in the ministry side, I think we need to have a very good public relation, because most of the news items, I think we have to revisit. That also part and parcel of this good governance. Then we come to the resilience health system. I think Dr. Krishna discussed about this resilience health system, and we are one of the director of the European Observatory of Health System Policies. He mentioned the resilience goes beyond the concept of sustainability and performance. We discuss about the sustainable development goals and all. So it means how we are going to discuss about the resilient. Now how Sri Lanka react after, say, 2009 war. Then again 1977, the economy, the free economy being introduced. So how like the country been having this resilient mindset. So in that particular scenario, where we need to understand how we can relate this, the resilience with the good governance. So this particular quotation I considered as really important. there were many aspects crucial to resilience within a system. First of all, decision making had to be transparent and affected parties need to be engaged in the process. What is this affected parties? So we need to identify some benchmark success stories in different countries in the world in the health system. The stakeholder means all the interested parties, we have to come into the decision making. Integrity should be ensured through clear jobs and hiring tenure, while policy analysis always needed to be central concern. The policy analysis we need to take into consideration. So in that particular scenario, I think this one of the article I have published few years back in Good Governance, by looking at the Sri Lankan context, I think 2015, the new government that time was appointed by promoting the word of good governance. But unfortunately, the good governance, the word being not properly articulated by that particular government. So because of that only, people start to think like there is no any relationship between good governance and the resilience. But we need to keep people aware. Even by looking at the context of this good governance and all, I think we can have a kind of a short course for all the medical professionals for this good governance, because not only it is talking about something we need to do as an institute, the individually professionals also we need to maintain certain ethical and transparent practice. So that is really important. Again, I will reiterate, ethical and transparent practice. So that part I think we considered as really important. And one of the success story, our neighboring country in India, where I have cited the good governance, patriotism and doctors. So people start to ask a question, then what sort of a thing we do with this good governance and patriotism? One of the article where on 11 December 2014, the Times of India, they published one article, how you can ally both good governance with patriotism. So this is something very interesting. Right? The senior bureaucrats will soon visit schools. So they say, under the Prime Minister Narendra Modi, the Teachers' Day address to the student on September 5, in that particular year, Modi has suggested doctors, engineers and civil servants who wish to volunteer to teach select a school in their neighborhood and visit to share their learning experience. What are those topics? They will go and discuss about ethics, nations building, environment protection, development and good governance issues. So it means this sort of best practices we need to inculcate, not only the medical doctors, chartered accountants, professionals. So we need to, we can be considered as the opinion leader for this country. Whatever the country, the opinion leaders, professionals, people start to respect. You talk in front of school children, you need to have some ethical considerations as well. You should be very transparent, you need to be very much concerned about ethics, because this can be considered as how, as a country, as a nation, so we have to build towards to the, whatever the next 10, 20 years development. Unfortunately, still I could not see this sort of a kind of a strategies being adopted in Sri Lanka. But no need to reinvent any, we are talking about reinventing wheels and all. So the best practice from our neighboring country, we can take into consideration. So to the society, there is a huge respect for teachers, medical doctors, but that respect, how we are going to operationalize, that also I think we considered as part and parcel of this particular discussion. And also, yesterday, in our school, I met, I think, Professor Samadhi Rajapaksa. He has published a book on this, Glimpsing at the Journey of Palliative Care, one of the book, where by talking with him and by looking at this particular book, I consider these are the best practices we need to inculcate. Comes under good governance, comes under patriotism, again the community work. So we need to propagate, communicate this sort of a message, not only these publications, for the general public, because journal publications and all, I think I already published, say, more than 100 journal articles for international journals and research conferences, but the article I usually publish in a newspaper in singular medium, I get more satisfaction, because we talk to the general public, because we need to repay whatever things we gain from the general public. And also, I think Dr. Sridharan, where this success story of Mahayangani Base Hospital. So these are the things really important for us to close to the general public, then to understand the heart, rhythm and pattern of the general public. I can remember Dr. Asela, he has done his master's research on brand equity, where the Kalupovil Hospital brand equity is higher than most of the private hospitals in that particular area. So people always select Kalupovil Hospital, not the private hospitals. So how, not the private sector we are talking about, the government hospitals, what sort of brand image we have. So these are the practices we need to be very much concerned about, align with the concepts by looking at the different definitions. So my own suggestions. So my reflections, my suggestions, everything we need to take into consideration. So by considering all these definitions, operationalizations, and by looking at all the articles and all in good governance for the resilience, the ministry and individually, we need to have accountability. The accountability is utmost important. Second one, the ethics. I think we need to put ethics as number one, maybe accountability as number two. So what sort of ethical practices we are going to perform? If someone come to the hospital, then whether we are going to refer that person for the private lab. So these are the things we need to talk to my heart and take certain kind of decisions, ethical considerations. That is really important, because now we are in the bankrupt country. We have to build up this country with the transparent way. Transparency is really important. Then efficiency and effectiveness. So we can see, like now last few years in the health sector, the efficiency and effectiveness been improved. People always talking about the COVID, how we have won the war against COVID-19 and all. But there are certain aspects we need to take into consideration. And in the Open University, as a chair of Strategic Management Plan 2 years back, we incorporate one particular goal on good governance and CSR. So we incorporate 6 goals. Goal number 1, 2, 3, 4. Then under goals we have objectives, strategies. Then by considering certain KPIs, with the activities, then we can have sort of alignment. And the media relationship. Unfortunately, with the social media, it's very difficult to manage. But by looking at the public relations, by looking at the way you are going to manage the social media and all, there are many best practices being adopted by different countries. So that part also we need to take into consideration. I'm not telling all these social media we need to reply, but we can pick the algorithm we need to understand. There should be at least 2 to 3 trainee, maybe members, always concerned about the dashboard. What sort of a positive and negative media messages coming for the ministry, maybe for the individuals, then how you mitigate. So it can be considered as an investment, because we have to aware people about the actual scenario. Then public health education. Still, I can remember 25, 30 years back, we always like to watch the television program by Tusita Malalasekara, Dr. Tusita Malalasekara, and I could not remember that professor, Nandadasa Godagoda. අපි ඒ කාලේ හරිම සන්තෝෂෙන් මේ නරඹපු ටීවී ප්‍රෝග්‍රෑම් එකක්. නන්දදාස ගෝදාගොඩ මහත්තයයි තුසිත මල්ලසේකර මහත්තයයි. තුසිත මල්ලසේකර මහත්තයාගේ පුතා මං හිතන්නේ ඉන්නවා. The son of Tusita Mallasekara, doctor, yes, he is there. So still I met the father, he's willing to join for the programs. Even though like he's around 65, 70, the energy is there. ඒ කතාව අපි අහන්න ආසයි. නමුත් වර්තමානයේ අහන කතා ටිකක් මට මදි වගේ ගතියක් තේරෙනවා. I don't know whether that energetic way of talking. Professor Nandadasa Godagoda is the person who introduced many Sinhala words for the people. So that also part and parcel of these particular strategies. And the relationship between each category of staff in decision making. Stakeholder meetings. This time in the Open University, not only the university lecturers and all, we get the participation of general trade unions also for the strategic management plan discussions. Then you feel like you get the ownership. Maybe nurses, maybe the other minor staff members, not everybody, but few people, stakeholders getting into action, then again we can have a kind of a good roadmap for the future. Because why I am telling you, so what we need to understand, I think I just want to quote, this is one of the very interesting quote where I always admire late most venerable Madiya Panyasiya Thero. One cannot develop a country in its true sense without the moral development of a man. So Aragale and all you can't do without developing yourself. Struggle should come from you, your inner sense, spiritual sense. You can't make change for the country without changing you. So, need to go to goal-face, but before that we have to change ourselves. So that of course you need to understand. Why I am telling you like this? So these are the basics we can say. People blaming for supply chain management and all. One of the Daily Mirror report, 67 billion being wasted in Sri Lanka every year, 550,000 metric tons of fruits and vegetables. All the people start to blame to the government, to the supply chain experts, but there is a health factor also associated. Why can't we promote Sri Lankan vegetables and fruits for the general public? සුපර්මාකට් එකට ගියාට පස්සේ අපිට තියෙන්නේ ඉම්පෝට් කරපු එළවලු පළතුරුනේ තියෙන්නේ. මෙඩිකල් ඩොක්ටර්ස්ලාට පුළුවන් කියන්නේ නැහැ. pear ගෙඩියක නියුට්‍රිෂන් වැලියු එක වැඩි ඇපල් එක ගෙඩියට වැඩිය. So then this supply chain, whatever things wasted, maybe we can reduce at least 0.5%. So how we promote the nutrition value for our own products, our own vegetables and fruits. So it means technically whatever the things happening in the environment preface, we need to understand there is one particular responsibility of ourselves as well. So that is really important. So where I think this is one of the articles I have published for Daily News, the oath of Kannangara. I think everybody here, so we have to repay whatever things we gain from the free education. Where in this article I propose, every citizen in Sri Lanka early morning or maybe in the office, you have to take oath of Dr. Kannangara because of the free education. Then only the transparency, ethics and everything will come with the good governance. Good governance, if you really study the history of this country and the civilization, no need to read good governance, we practice good governance with our culture. So that part actually we need to understand. So anyway, you know, John F. Kennedy can be considered as still the most popular president in US. So in inauguration speech, he mentioned, ask not what a country can do for you, ask what you can do for your country. So this is one of the very important things. Now, the professionals like you, this country needed more. So there are many migration opportunities, I know, but there are certain obligations we have because there are many things we missed, but many things need to be understood. So that is one of the message I just want to tell you. Thank you very much.
Thank you very much, Professor Nalin Abesekara, for bringing local flavor to the role of good governance in building a resilient health system. And your suggestions are well taken. And you spoke about 550 tons of vegetables and fruits wasted. And even it was discussed in the parliament also yesterday. Yes. And you quoted the CWW Kannangara. We are talking about CW Kannangara because not of his is very rich or very affluent person, because he brought free education to Sri Lanka. So keeping that in mind, again I wish to thank Professor Nalina Besekara. And next, I'd like to invite our next guest speaker, Dr. Sundararajan Gopalan. Dr. Sundararajan Gopalan is online now? Is on Zoom? Is on Zoom? Zoom, ne? Has he joined us? No, wait. Okay. With that technical issue, we'll go to the next speaker. Next speaker will be Professor Tan. He'll be talking on future of regional health. Clinical Associate Professor Tan Hyang Koon stands at the forefront of global health, serving as the director of the Sing Health Duke NUS Global Health Institute and the group director of Sing Health International Collaboration Office. As deputy CEO of the Future Health Systems in Singapore General Hospital, Professor Tan has made a remarkable strides in clinical leadership. His visionary role in forming Sing Health's first head and neck SDDC in 2013 transformed patient care, culminating in the integrated division of surgery and surgical oncology in 2019. Undiscouraged by the COVID-19 pandemic, Professor Tan steered massive project establishing 3,700-bed community care facility safeguarding Singapore's healthcare capacities. Professor Tan is passionate about global health and has established a global surgery program in surgery ACP with a clear vision anchored by strong academic principles. He co-led Temasek funded project Quality Assurance for Healthcare in Sri Lanka, focusing on building capacity and management expertise in the health system. He collaborated widely with the international partners, including Ariane Lab, Duke Health, and regional hospitals. His global health project with the Duke title Partnership to Establish a Practice-Based Network to Assess for Head and Neck Cancers using a low-cost, portable, flexible nasopharyngoscopy won a $3 million ROI grant. He has recently initiated a Pan-Asia Surgical Leaders Network to study the response and impact of COVID-19 pandemic to the surgical health systems, aptly named COVID Impacts, COVID-19 Impact and Action Taken in Surgery. 36 surgical leaders from 25 Asian hospitals in 11 countries have thus far accepted the invitation to participate in this collaboration. His dedication extends further as a founding chairman of the Children's Cancer Foundation Singapore. He raised significant philanthropic funds to support oncology and surgical research. Today, we honor Dr. Tan's relentless commitment to advancing global healthcare standards and his remarkable contributions to the medical fraternity. Over to you, Professor Tan. Thank you.
Is the slides on? Great. Hi, very good morning to all of you. Sorry I was a bit late, I was held up by a meeting. And also walking over from Grand Cinnamon Hotel. And Vijaya warned me that I shouldn't cross the road. I should cross the road only at where the traffic light is. And so I stood in front of the traffic light and I pressed the button and waited. And waited. And waited. And finally, a very nice local came over, took an umbrella, just walked in front of me, and all the cars stopped. Then I realized that that's what I was supposed to do. And thankfully, it was just, the light rain that you see sometimes in Europe and not the pouring rain that we often see in Singapore. Anyway, I'm absolutely delighted to be here today. I know that the topic that I was supposed to talk about is the future of regional health, and I thought I would sharpen the focus a little bit and talk about the future health, looking at the mega trends and the challenges that we as a healthcare community and all of us as healthcare administrators are likely to face in the coming decades. And that asking the question whether we can do more with less. I have no conflict of interest to declare. Next. Oh, right, okay. Where do I point? So I'm going to look at maybe some of the mega trends that we are facing. And I think this is a common mega trend that we're going to see globally, but in many of these, particularly in our part of the world. It is tremendously difficult to predict the future, but I think if you set your eyes firmly on these mega trends are not likely to move, and hence the ensuing consequences and problems brought about these mega trends gives you an idea where we should be focusing our efforts and attention to address. Now, many Asian countries are facing these rapid rates of population aging. In Sri Lanka, I think by 2035, about a quarter of your population will be above 60. Or in that regard, Singapore has done a little bit better. We just get old a bit sooner. By 2030, a quarter of our population will be above 65 years old. In my hospital, by 2030, about 25–30% of the medical healthcare providers will be above 65 years old. So this, of course, has a direct impact on all the type of diseases that we're going to see, and also the burden of the diseases we are likely to see. The other mega trend is the rising health expenditures. Now, globally, the expenditure for healthcare expenses has really gone up, double in the last 10–15 years. This is projected by the Lanka Commission. In Sri Lanka, I believe that your healthcare expenditure per capita has increased by 40% in the last decade. Now, in Singapore, from 2010 to 2019, our healthcare expenditure has gone up by threefold. And it is projected that unless we do something to change, by 2030, this is going to be tripled again. In other words, within 2 decades, healthcare expenditure will go up by a good 9 to 10 folds. Now, no health system would be able to sustain that kind of increase in healthcare expenditure. And this is a global pattern. If you look at the OECD 40 countries and you track their healthcare expenditure over their GDP spend, you see that invariably across that last 30 years, the graph goes this way. In other words, people and countries are spending more than what their GDP can afford. The third mega trend is the climate change. I think this as small island nation, both Sri Lanka and in Singapore, of course, you're much bigger than we are, but we understand how climate change can affect our country. And climate changes has got many facades to it. It has a direct interface into the kind of diseases that we're going to see. It impacts migratory pattern. It impacts also how the human interface with the environment, and with that, all the zoonotic transmission, it worsening air and water quality carries a different type of disease pattern, etc. And us as a healthcare industry, we are contributing, unfortunately, into the climate change issues. In US, healthcare is already the leading enterprise. Now, with all the economic activities, it does mean that they consume more energy. It also means that it contributes more waste. And it is projected from 2000 to 2015, the carbon emission is going to increase globally due to healthcare activities by about 30%. A lot of this, in fact, came from, interestingly, drug procurement and how drug is being produced. Some of these really are beyond the scope of our health system, but we can do our parts to it, not just on reducing the energy consumption, but also how we deal with the waste product of healthcare. This is another big thing that we're facing us, which is the healthcare workforce shortage. The WHO predict that there will be a shortage of about 10 million healthcare workers by 2030. And Sri Lanka has faced an increasing migration of doctors, unfortunately, in the last few years. And we in Singapore, we're facing the same thing. We have a shortage of about 240,000 healthcare workers. I'm sorry for this. This doesn't respond sometimes. Where should I point to? Do I point there or here? Doesn't seem to move. It is responding to here or no? Okay. The other mega trend is that the technological advancement is really coming to us fast and rapid and quick. And we as a health system, if we want to rely on technology to tackle some of the issues that we have, then we need to bring on board this technological advancement. But it also means that we have to adapt and we have to change. And that itself causes challenges, it itself causes the stress to existing healthcare workers, and something that we really need to look at. And which leads me to the last point, that healthcare worker burnout, it is real. It is certainly a lot more evident now coming out of the pandemic. The burnout rate is ranging from 40 to 50%. We did our own studies across Southeast Asia, and we have the prevalence of burnout around about 50% of the healthcare worker population. Long working hours, high job risk, availability of personal protective equipment are all associated with the higher odds of burnouts. Now, in the face of all of these mega challenges, you will note that the pattern emerges that these challenges, they are interrelated. Aging population will increase the workload. Then you are faced with a workforce shortage, which of course lead to burnout, and there's also increased expenses. And when you have more workload, you increase your carbon emission, etc., etc. It are all interrelated, and unfortunately, they are negatively synergistic. But this is not a hopeless situation, because if all of these factors converges, then it also means that you are likely to be able to find solution, and you find solution to one of this, you are also likely to address a few of these challenges. So how do we tackle them? And I think this is what we are looking at, right? Healthcare in the future, really less is more. It is not a good to have, but it is a must have. We have to do more with what is available to us, and it's likely to be less than what we are probably having now. And in order to do that, there are a few definite steps that we need to do. One is we need to reduce the disease burden. Two, if we cannot prevent the disease, we have to decrease the footfall into the hospital. Because the hospital is labor intensive, it's energy intensive, and it's financially intensive. We need to reduce our reliance on labor. We are a high-touch industry, yes, but that notwithstanding, we just don't have enough healthcare workers to go around. And there are some measures that we can take to address this. Last but not least, the changes are going to come rapid and fast. How do we prepare our workforce and motivate them to accept and to embrace these changes positively? So let me just cover each of this. Lowering the disease burden. I must say that as far as this goes, I think Sri Lanka really, we got to learn from you, right? You have set out division of preventive medicine. You have done this way before everyone else have done so. You have done outstandingly well in your MCH programs. All of this because you have taken proactive steps to stem the disease right at the community level. But increasingly, we are also seeing that these habits has to come from an early age. I'll give you an example, right? I've got 3 daughters. All of them don't like to eat vegetables, like most children. We don't cook our vegetable the way that, you know, the Sri Lankan food, where the stew is wonderfully flavorful, so they're not a big fan. But my youngest daughter, of late, has been coming back home from school and has been asking, this week will be asking for broccoli, the next week will be asking for cauliflower, and that really surprised me, right? Then I realized that they have changed the curriculum. Now in the physical education, they incorporated dietary lessons, and she's curious about this, and she's asking for it. And that's quite a clever thing to do, because, you know, when you have a little kid coming to a family and asking for a particular type of food, it does change the diet of the entire family and not just the kid alone. And of course, cultivating these good habits young, hopefully it carries on to the adulthood. And I think where we cannot prevent the illness, we want to prevent serious illness, because it then decreases the demand and the burden on the health system. Now, recently, Singapore has launched this Healthier Singapore initiative. This is an initiative that is a follow-up on a 2015, in 2015, Ministry of Health Singapore has launched a 3 Beyond strategy. Beyond quality to value, beyond hospital to community, and lastly, beyond healthcare to health. And you can see the drift, right? It is about prevention, it's about moving into the community care. Now we have taken one step further. We are putting up definitive measures to execute these concepts. One of which is that we are moving into capitation model. In other words, now, based on the demographics on the population that is assigned to you, you are given a certain amount of money to manage, and however you want to manage it, it's up to you. In the past, if I do 100 surgeries, I claim from the government 100 surgeries. But now, money is given to me right up front, right? So the more unnecessary things that I do, the less I will have in my kitty. So if flip the concept around completely, we used to say in healthcare, if you see healthcare as a business, then your patient is your client. But now, even the healthy people are your clients, because the healthier they are, the less likely they are going to fall sick, the better it is for you as a business, so to speak. So this whole national strategy really focus on preventive care by empowering individuals to take active steps toward managing their own health, and with the support of family clinics and community partners. Again, something that Sri Lanka has done for years. And just to kind of illustrate how this is going to be executed. So for instance, SingHealth, Singapore health system, which I come from, is our largest public health system. We're assigned a certain population, which is sort of east and southeast of Singapore. And we divide those into 15 precincts, and each of these precincts has maybe about 40 to 50,000 people. And we form what we call the Healthier SG team, Healthier Singapore team. And what does this team look like, right? It has 4 components. It has got primary care providers. In Singapore, 80% of these primary care providers are private clinicians. We have community nurses. We have a well-being coordinator, and they are not necessarily medically trained, but they are very, very familiar with the community resources. They work with the NGOs, they work with the church group, they work with the welfare groups in the community. And last but not least, you have a social partners, which are all of those things I mentioned earlier. So this is truly a public-private social kind of a partnership, right? And the idea is that we work with these partners to not just do treatment, prescription, prevention, but we also do what we call social prescription. For the elderly, sign them up for dance classes, Apparently music and dancing really prevent the early onset of dementia, right? If you believe in mahjong, that's another way of doing it. Send them to mahjong clubs, so on and so forth, but you get the drift. And therefore, anchoring this care in the primary care and the community, and we only refer to the SingHealth institutions, right, the tertiary institutions for the complex and the tertiary care. You can see that in SingHealth, we have got a really multi-tier system from primary, secondary, tertiary to quaternary care. And with the Healthier SG team as a coordinating group between the tertiary institution and the community, we hope to be able to keep the care as much as possible in the community, or even better, keep them healthy so they never ever need to get there. But if they do need to get there, there's a tiered referral patterns so that the right care is sited to the right place. Let me move to the other part. What happens when you cannot prevent the disease from happening? Obviously, if you can, that's great, but sometimes you can't. And when you can't, you still, as far as possible, want to reduce the footfall into the hospital. And this requires a decentralized, patient-centered care. And for that to happen, it's a tripartite relationship. It requires a very close working relationship between the hospitals and the primary care providers, as well as the patients. And central to this is that the data must flow. What is accessible to a tertiary institution must be accessible to your primary care physicians and must be accessible to the patients where applicable. This is how you enable the patient, empower the patient to manage their own health. So we talk about this, digital hospital, and there are many versions of this, and in fact, it is not easy to really hone down to what exactly do we mean by digital hospital ecosystem. But I would submit to you that it is certainly a lot more than what you will see in a brick and mortar hospital. It's not just about building a smart hospital. It's about taking the patient's journey from when they are healthy through to pre-diagnosis, to diagnosis, to treatment, to post-treatment care, and back to the community. It's an entire patient journey. It requires multiple partners to work seamlessly together. Patients, the doctors, drug stores, the circulation enterprise, the logistic enterprise, the medical payment system, your other medical entities, and your social and health group. All of this has to be linked up in a digital platform to allow us to build this digital ecosystem. Digital hospital has been spoken about for a very long time, but I have yet to see a cogent, cohesive digital hospital system that provides an experience for the patients that is equivalent to a brick and mortar hospital can provide, which is maybe why at this current moment, patients still prefer to see a physician face-to-face. But I am convinced that this will change. I have no doubt that this will change. And if we as healthcare administrators and managers do not change the processes, we are not only doing our patients a disservice, we are in fact doing ourselves a disservice, because this is a Kodak moment. You know how Kodak, although they are the first that invented digital film, they decided not to invest in it because it cannibalized on their physical film, right, industry. The more people go digital film, the less they'll process their paper film. As a result of which, they killed the project, but it eventually led to the demise of Kodak. And I think we are right there looking at the abyss right now, and I think we as a healthcare community really need to embrace this for the sake of patients. And there are pockets of this that has been successful. I'm going to show you some of these examples. Johns Hopkins has started this hospital-at-home concept, and they found that it costs 32% less. It reduced the length of stay from 4.9 to 3.2 days, which are a significant reduction. It also reduces the incidence of delirium. Now, that is very important because with the aging population, that's what you're going to have when you put elderly patients into an environment they're not familiar with. The patients feel satisfied, and there's no difference in the readmission rate. In Australia, in Victoria State, they did the same thing. They provided 6% of their hospital bed days, they provide them at home. As a result of which, this led to a lot of bed days being liberated within a brick-and-mortar hospital. Now, we embark on this journey as well in 2022. Happy to share with you some of the outcomes. In Singapore General Hospital, where I work, we have launched this mobile inpatient care in Singapore, otherwise known as MIC. The patients are admitted to the hospital, and they are assessed by what we call the MIC team, and if they deem suitable, the patient are moved to the home, and you have patients being daily reviewed by team that either visit them at home or through a teleconsultation. And of course, we use IoT to do monitoring as appropriate. And once a patient has recovered, they get officially discharged from MIC. The process is like discharging a patient from an inpatient stay, and they then move into the community. And since launching this and has a pilot study in April 2022, we have saved about 7,000 patient bed days. And it is multidisciplinary. But this is still a very small proportion of the patients that we see, and we hope to be able to scale this to about 10% of hospital admissions by 2027. But the truth is that if you ask me honestly, I would say that is insufficient. 10% of current hospital admissions being taken care by mobile inpatient care is not sufficient to address those challenges that we're going to have and we're going to face. We've got to think a lot more than this. Is this 20? Is this 30? Is this 40? Is this 50? I don't know. But suffice to say that 10% will not cut it. Let me move to the third part, which is reducing labor intensity. I'm just mindful of time. How much time do I have? 10 minutes or so? Okay. How do we reduce labor intensity by increasing the efficiency? I know when I said this, many managers, administrators are going to say, really, you want us to work harder? But that's not it, because it's hard to make us work harder than we already are, right? But it does mean that we hopefully are able to work smarter. Now, there are certainly evidence to suggest that there are many things that we can potentially do. This is a study, OECD, that showed that 79% of nurses and about 3/4 of doctors feel that they are doing tasks or performing tasks for which they are overqualified for. I.e., we are not allowing our healthcare professionals, which we painstakingly train them, to perform at the apex of their license. We need to think about task shifting. You look at a person's job, a doctor's job, you track their role over the 24 hours, apart from the time they're sleeping, and then you think, these things that they do, what can this be done by someone else? Can this be done by a different type of workforce that does not require you to go through 5 years medical school, your training as a SHO, and so on and so forth? And the same applies to our nurses, and the same applies to our allied health professionals. The other thing that healthcare industry, generally as a group, we don't do very well. Certainly in Singapore General Hospital and SingHealth, we are only beginning to sort of pay attention to this. It is about performance management. How do you keep track of operational performance? How do you design a performance system whereby the clinicians, the administrators, the allied health workers are all tuned towards the optimal performance? If we think that our healthcare, our people are our most prized asset, have we maintained them at the top of their form? It's a little bit like a F1 car, which is, you need to finely tune them, you need to have maintenance, you need to tweak performances, etc. And so that on the track they deliver the best performance possible. The truth of the matter is that we don't. And you know, I sometimes ask the question in the audience and said that through the time that you are a SHO to the time that you are now consultant, can you put up your hands and tell me how many times have you had a meaningful, impactful performance appraiser from your bosses? And certainly in Singapore, I don't think I will get even 10, 15% of people putting up their hands. I don't think that's because they are shy, because it did not exist. It's certainly, in my case, I don't remember my boss ever telling me about doing a proper performance appraisal, right? But that would be needed if you truly want to extract the best out of people. And the other thing is of bureaucracies. And we have them. Singapore General Hospital has 200 years history, and the older you are and the bigger you are, the more you accumulate them. Because when they design the things that put in place there, at that time it sounded like a good idea, but you know, time moves on, and we never take things away. We're suffering from this tyranny of addition. We never take things away. We just keep adding processes. And with that, in fact, recently we just launched this interesting campaign, and we call it GROWS. GROWS stands for Get Rid of Stupid Stuff. Now, you're laughing, right? Because I think every one of us gets it, right? Because There are so many things that we are doing in our day-to-day, especially administrators. I think healthcare managers, we see that. But it doesn't affect us. It affects every layer of the hospital workforce, from the porter all the way up to your senior consultants. We are having to deal with stupid stuff because at that time that it was formed, it's well-meaning, it's well-intentioned, but time has passed on. So it is no longer relevant. And how do we do with them, right? So we launched this campaign. It's called a growth campaign, right? And we say, why do we need to do this? Because it adds to the administrative burden. It causes frustrations. It makes people burned out and they feel overwhelmed by their work. And these are not meaningful work. And therefore, getting rid of stupid stuff is good. It gives you more time to interface with the patient. It energizes your workforce, and it makes the organization agile and nimble. And there are various themes. You can just take a look at it. And what this is: compliance, is redundant workflows requirement, irrelevant mandatory training requirements, IT inefficiencies. That's a favorite, right? IT inefficiencies, and some of these are also personal inefficiencies. But all of this, when you add them up all together, it adds up to a significant amount of your healthcare workforce, which you have so little of, and we are not extracting the best out of them. And we also set some rules, right? You want to get rid of stupid stuff, the few things that you do, you start small, you start within your things within your own control. You don't have to have the hospital director tell you to get rid of stupid stuff. Get rid of it yourself, those that's within your control. And don't pass it, because you don't want to do it, don't pass it to another department to do it, right? And you need to do very extensive stakeholders engagement so that people, you can see different perspectives. What may be stupid to you may not be so stupid for another person. Encourage. And then also to always celebrate small wins. Okay, I'm going to come to the last part of the talk, which is how do you decrease the barrier to rapid adoption of technology? And this is something very close to my heart, and this is something that I believe we just have not paid enough attention to. We all know the challenges coming up. We know that we can leverage on technology, but have we done enough to prepare our workforce for it? We need an agile, adaptable, a motivated workforce, and how are we doing that? If you look at how technology is evolving, this is a graph that plots from the time of agricultural revolution to industrial revolution to the invention of light bulb, moon landing. You can see that with each successive human milestone, significant human milestone, the time between each of these milestones is getting shorter and shorter. This is a graph that plots the adoption, a universal adoption of a new technology, from telephone, which takes about almost a decade before it becomes widely available, to electricity and car. But look at much later, you see your smartphone, your tablet. Each of these reaching universal adoption, it takes less than a decade. A deeper dive into this will tell you and show you that innovation goes at an exponential rate, right? But we, organization, and us human beings, which makes up the organization, we move much slower. We are analog, right? We don't go exponential. And that gap between where the technology is and where we are is the innovation gap. And that is what is going to give a lot of stress to the people that we are working with. If you look at some of this technology, they managed to get users very quickly. Netflix takes 3.5 years to get 100 million users. And you move on to ChatGPTs, it takes 5 days. Now, how many of you have used ChatGPTs? Please put up your hands. Okay, I would say maybe at this current moment, it looks like maybe 35, 40%. For the rest of you who haven't, if you haven't tried, please go try it. Today, when you get home, go to ChatGPT, it's free. The version 3.5 is absolutely free. Have a chat with ChatGPT. It can change your life. And what I wanted to show you about that slide is because when you have got things which can be rapidly adopted because the technology makes it so simple. But unfortunately, in the healthcare, the technology is often not plug and play. It requires you to develop those technology, make sense of the data. You need to work with various stakeholders. You need to interface the stakeholders with the machine. You need to develop that learning ecosystem. It's a much longer process. And typically in the health system, this came from NHS. We spend a lot more time buying new technology than we are willing to invest in implementing them. We spend less than 5% of the cost of purchasing new technology when perhaps we got to spend a lot more in investing how to implement this technology. You need process engineers, implementation scientists, behavioral scientists, because you nudge the people the right way is how you can adopt this technology in a quick and fast way. The typical organization on the left-hand side, what we call the classical hierarchical leadership structure that exists in most hospitals today, including mine, the evidence apparently shown that it takes 17 years to adopt a evidence-based practice. 17 years. That might be okay 50 years ago. That is not okay today. In 17 years, you have 3 different versions of the best care. You will always be doing catch-up. So we got to move the way that we allow our organization to be flatter. We have distributed leadership. We have leadership on demand, and people take on different roles and champions different roles. And us as leaders, our role is not so much as the commander in the general or a general of an army telling people where to charge. We are a little bit like shepherd, right? Just herding and ensuring that all people are going in the correct direction, because if you energize the people, they will make the right decision. So I'm going to conclude to say that to create an agile, motivated workforce is critical. It requires patients and the staff to participate in building the future. We need to build the capacity for us to adopt technology quickly. Communication is key. We need to upskill, reskill, and celebrate all the successes. Create a culture of openness and innovation. And if you want certain guidelines about how do we create this workforce, there's probably a few very simple things that you can ask, right? This came out from a book I was reading. In fact, this is a Harvard Business Review. What is a dream company? It's one that you can be yourself. You are told what is really going on, not, a sanitized version of what is going on. You want to work in a place where your strengths are magnified, that the company stands for something meaningful. That in healthcare, we never have a problem, because we always, if we do our job well, we stand for something meaningful. And with that, your daily work should be rewarding. And last but not least, stupid rules don't exist. And if they do exist, be gross, get rid of it. So with that, I submit to you that the future health system must do more with less. We must do this by reducing disease burden, decentralize the care, reduce the labor intensity, reduce the barrier to the change. We've got to rapidly adopt technology and innovation to help us battle these challenges. And we're going to find a painless way, or at least a less painful way of doing the adoption. This requires that we deliberately and systematically invest in an agile, adaptable, and motivated workforce. With that, I thank you.
Thank you, Professor Tan, for that wonderful presentation. I think there will be a lot of questions during the panel discussion. Okay, so next we are moving towards the last presentation by Dr. Sundarraj Gopalan. Is he online? Okay. Has he joined? Yes? Professor Gopalan, can you hear me? Okay, so shall I introduce him? So, meantime, I'll introduce Professor Sundarrajan. Yes. Good morning, Dr. Gopalan. Yeah. Dr. Sundarrajan Srinivasa Gopalan, a public health physician with about 40 years of international professional experience. Dr. Sundarrajan S. Gopalan comes from India and has lived in 12 countries. India, Nigeria, USA, Denmark, UK, the Maldives, Trinidad and Tobago, Bangladesh, Nepal, Sri Lanka, Myanmar and Malaysia, and worked on many more. After his medical degree from Jipar, Pondicherry, India in 1976, postgraduate education in community medicine from Banaras Hindu University, Varanasi, India in 1980, and Masters of Public Health from Johns Hopkins Hospital, Baltimore, USA. He has had a long international public health career. His work experience include management assistance, assignments, principal of a school health technology in Nigeria, associate director of public health in London, technical assignments with the World Health Organization, both in its European regional office, Copenhagen, and its country office in Maldives, operational team leadership in the World Bank in several countries of South Asia and African regions, and a senior advisory role in the health sector reform advisor to the Ministry of Health in Trinidad. And also he was the project director for first health sector development projects of Sri Lanka. After retiring from the World Bank Group in 2018, actually from Sri Lanka, he has been undertaking consultancy assignments including the following tasks: operations advisor to the World Bank Group's health team in Myanmar, health policy advisor, universal health coverage with the World Organization in Myanmar, lead consultant for the preparation of Gavi HSS proposal in Bangladesh, lead consultant for a World Bank study on incentives for nutrition. Outcomes, lead consultant for the multi-sectoral capacity assessment for nutrition in Myanmar, lead consultant for the preparation of WHO's biennial country presence report, and the lead consultant to prepare the discussion paper for the World Bank on multi-sectoral whole of society approach in combating non-communicable diseases. His areas of professional interest include universal health coverage, health sector reform, health system strengthening including health financing, health policy and management, nutrition, public-private partnership, monitoring and evaluation, health information systems, HIV/AIDS donor coordination and partnerships. Also, he was the external advisor for the recently developed sustainable health financing strategies for Sri Lanka, and hope to work with him in future also. Over to you, Dr. Gopalan.
Thank you so much, sir, for this very kind introduction, very long introduction of all my career. Thank you very much. So I don't have to say anything more about myself. I will go straight into the presentation. I'm going to share the screen and hope that you will be able to see it. Can you see the screen?
Yes, we can see.
Okay.
We can see Dr. Gopalan.
Okay. So basically, let me start by setting a context for this presentation. Sustainable health financing, planning the way forward was the topic given to me. But I wondered, what is the background, what is the context in which this will be presented? I'm trying to go to the next screen. I'm not able to. Can't I move this thing here? Okay. So the context is universal health coverage. So basically, the whole idea of financing becomes more important. Universal health coverage means all people receive the health services they need without financial ruin or impoverishment. Financial ruin, otherwise called catastrophic expenditure. See, the key points here is all people. Everybody should be covered. Universal means everybody. The services is also all the services they need. It is not based on what services they pay for, what services are available. They should be able to receive all the health services they need. And that includes health promotion, prevention, treatment, rehabilitation, palliative treatment, community health, health centers, action on social environmental determinants. So everything, not only within health sector, but also beyond health sector. Now, when you look at universal health coverage, there are three broad areas of inputs into it and three broad outcomes that come out of it. The inputs have to be in the health system strengthening area, they have to be in non-health sector actions, and they also have to be in behaviors, individual and household behaviors. All of those three put together will ensure that universal health coverage is achieved, and that if it is achieved, it should not only improve in health status improvement, it should result in financial protection, it should also result in citizen satisfaction. So, as I said, it's fundamentally about equity. That means everybody will be covered, nobody is left behind. The health services are according to need, not according to some clinical requirements and so on, but according to their need. The health financing contribution should be according to one's ability to pay. So, irrespective of how much I am willing to pay or able to pay, according to the need, I should be able to get all the services that I require. The healthy subsidize the sick, the wealthy subsidize the poor. This is a very basic concept in universal health coverage, because if everybody has to have all services they need and some cannot afford to pay, then how will that happen unless the subsidy works? So this is a very, very important concept. Now, this is a very common cube that is being used to show the three dimensions of universal health coverage. The three dimensions are economics, health, and politics. Economics, because how much of the financing is covered. Now, it may cost me $10,000 for a certain thing, but will all the $10,000 be covered, or will I have to pay some co-payment or whatever? So how much of the financing is covered? What services are covered? Not all services can be covered, because some may not be considered essential, some may not be affordable. So there is always an issue of what services will be covered. And similarly, who is covered? In some population may not be possible to cover, and so on. So of course here universal means we must cover everybody. We must cover as much of the needed services as possible, and we must cover as much of the financing possible. So all these three dimensions are important. Now, when we talk about financing the universal health coverage, there is a variety of sources. Now, here we talk about direct taxes, indirect taxes, etc. So, just one second, let me just, if I can, okay. Because the issue is that we have different sources of financing, and we have also one of the things called OOP, out-of-pocket expenditure. So out-of-pocket expenditure turns out to be a very big source of financing in many countries, and that creates some problems, even if that is financing the healthcare, but that way of financing is not really leading to financial protection. So that is something we have to think about. So key concepts are pooling and prepayment. So if you finance based on individual payment at the point of care, then that is not really conducive to universal health coverage. So if we can pool the financing, then we talk about the subsidy that I mentioned before, that can be achieved. Prepayment is also important, because if you prepay, then at the time of receiving the health services, you may not have to pay huge amount of payment. So if you prepay smaller amounts, it's kind of an insurance concept, but it doesn't have to be health insurance. It can be other ways of prepayment and pooling. So most important financing question are in these three areas: collecting, pooling, and provider payment or expenditure. So who pays, how much is paid, when is the payment, whether it is prepayment or out of pocket, whether it's compulsory or voluntary, these are all very important questions to answer. Pooling, at what level is the pooling done? At the central level, who will be part of the pool, who is excluded from the pool, who will administer the pool? These are all very important questions. Similarly, provider payment. Do we pay based on salaries only, or do we pay based on capitation, diagnostic related groupings, or we pay based on fee for service? So these are all very important technical questions that require to be answered when we start talking about health financing. Okay, so how to raise money? We all believe that there is more money needed for universal health coverage. So we can improve the revenue collection. There are some limitations, because there are limits to how much revenue can be collected based on the economy, based on the ability to pay, based on the efficiency of revenue collection based on effectiveness of revenue collection, etc. So but it is an important way to raise more money. We can marshal more evidence to increase the investment in health. Ministry of Health can give more evidence to Ministry of Finance to give more allocation. Again, there are limits to how much they can do because of competing demands. We can squeeze out some system inefficiencies or system loss, what we call a system loss. This is estimated at 20 to 40% of resources. So if we can make the system more efficient, we can release some of the inefficiencies, some of the money spent on inefficient services. We can reprioritize government budgets to give more for health and less for maybe some other sectors. Again, there are limits on how much this can be done. There are innovative financing methods. There are also more effective development partner funding that can be used. Main modalities of health financing. One first more common modality is collection, pooling, and expenditure are all done wholly by government. This is basically fully public finance, publicly provided services. Second modality is collection and pooling expenditure are done by private entities. This is fully private. That is, private health insurance plans can be done, or almost like a US kind of system, but US also now has significant portions in publicly financed and publicly provided services, Medicare and Medicaid expenditure, for example. Collection done by government, but pooling and expenditure are done, managed by autonomous body or outsourced private management. So this is kind of a hybrid concept. There is a fourth thing was pay-as-you-go systems, where only individuals and households simply purchase the services as and when they need them. This is the most inefficient service, most inefficient mechanism. There is no pooling, there is no prepayment, and this is not going to be enough to cover, especially the poor people, because they won't be able to purchase the services they need. So most countries have a mix of the above mechanisms. Now, why are we focusing on the financing function instead of focusing on, let's say, other aspects of system strengthening? All aspects of system strengthening are important, but this particular focus on financing function is because the efficient and equitable health financing is the key to solving many, if not all, of the challenges that we are identifying. There are three components, as I mentioned: collection, pooling, and allocation of expenditure. I will not repeat the details of that. There are some global experience that we have studied in different countries. In other presentations on this topic, I have presented Malaysia example, Indonesia example, Thailand, India, different country examples have been Vietnam, so Philippines. So these kind of examples have been studied, and most of these examples I am talking about, they have some similarities to Sri Lanka as well. In every country, what we have found is a proportion of population is unable to contribute to the taxes of insurance premiums, so they need to be subsidized. Some proportion of population, this proportion varies from country to country, but some proportion always need to be subsidized. So that means pooling of risks and resources. So it's not only resources we are pooling the risks. There are some high risk individuals, low risk individuals. It's like basically insurance concept. The rich will subsidize the poor, the healthy will subsidize the sick. Risk pooling works only when the pool is large enough. Multiple small pools are ineffective and inefficient. This is very important. There are many countries which have tried different pools, 3 pools and 4 pools. So that the more disintegrated these pools are, the less efficient they will be, because the subsidization, and then also if the pool is not large enough, what will mean? Some people are excluded, and the people who are excluded may be the healthy people. They may exclude themselves because they feel they are healthy and they don't need to contribute. So these are all issues that need to be sorted out. Otherwise, this whole pooling mechanism will not be efficient. Prepayment is superior to payment at the point of care. Basically, as I said, it is to avoid catastrophic shocks, because when I have to pay suddenly $10,000 or $100,000 or $80,000, then that's catastrophic. Whereas if I prepay smaller amounts earlier, then it is superior. Contributions from those who can pay need to be compulsory. Otherwise, the rich and healthy might opt out. So that's again another concept that we have to bear in mind. Separation of financing, purchasing, and providing. This is very important. I mean, Dr. Sridharan mentioned that I was a health sector reform advisor in Trinidad and Tobago. The main concept of that health sector reform was how to separate the financing and purchasing function or providing function. Now, the reason for this is that accountability will be increased. If I am the person who's financing and I am also the person who's purchasing, I am also the person who's providing the function, like Ministry of Health does all these functions, then I am accountable to myself. So the accountability is not very strong in that kind of system. It's critical that both the public and private actors play their appropriate roles. That's very, very important. For-profit and non-profit sectors both are included when I say private. So unless we do this, it won't work, because private sector has a very significant share of the market right now, and that's not going to change. I mean, it can change to some extent, but we cannot completely exclude private sector, nor can we exclude the public sector. So both have to work together in order to do that. So now this, I think already I mentioned, most countries have a mix of this. Sorry for a repetition of the slide. Now, there are some prerequisites for improving health financing. Political will has to be there, otherwise it will not work. And at the highest levels, these are something like the war on HIV or war on COVID. You need all hands on deck. We need the finance ministry. We need the legal actions. We need basically political will at the highest levels. It needs to be broad buy-in, dialogue and consensus building. So otherwise, even at the highest level, if there is a political will, there are always levels in middle levels and lower levels which can sabotage the reform. So we need broad buy-in. We have to define and cost a benefit package. Every country cannot provide all services. There has to be some sort of what is affordable, what is socially acceptable, what is societal preferences. So there are different factors that we take into account while defining, but more important also is costing. In Sri Lanka, they have defined a benefit package, but it has not been costed properly, and it is an iterative process. So you do that based on epidemiological need, based on cost effectiveness of interventions, and then you start costing it. Once you cost it, you say, oh, maybe it's not affordable. So we may have to cut something. What to cut? It's a very, very difficult process, but political process as well. Establishment of institutional mechanisms is very critical. Without proper institutional mechanism, everything will remain theoretical. If you want to implement it, you need to have a proper organizational home for the pooling and management of the funds. You need to have implementation mechanisms, institutional mechanisms that are effective, that are locally suitable to the country context. You can't import an institutional mechanism that works in India to Sri Lanka, or that works in Malaysia to Sri Lanka, because different countries have different administrative systems, different arrangements. Finally, provider payment mechanisms, I talked about 3-4 mechanisms. These are very critical things. And last but not least, strategic purchasing decisions, public-private partnerships. So some certain services, public sector may purchase from the private sector on behalf of the population, on behalf of especially the poorer population. So this is a very important concept. It's a new sort of relatively recently introduced concept in this whole field of health financing. And we are now talking about that in Sri Lanka. Now coming to Sri Lanka, some key data are important. Universal Health Coverage Index is around 66%. This is 2019 data. It may not have changed too much by now, I think. Maybe, if anything, it might have gone down a little bit because of COVID context. So I'm not sure whether this percentage holds. But even in this percentage, it's very good, but it's not 100%. Universal, as I said, must mean 100%. So there is still some room for improvement. Population in covering catastrophic expenditure is 5.4%. Population impoverished by health expenditure is 0.7%. Again, these are old data. This may be a little bit more after COVID economic problems, COVID, and then the subsequent economic crisis that Sri Lanka has been facing. So these figures might be somewhat worse. But the important thing is that even these figures, which look reasonably good, they are not good enough. We need to make them zero. There should be absolutely nobody who incurs catastrophic expenditure. Then current health expenditure, which is 3.8% of GDP, is quite low compared with countries of comparable economic status. Domestic government health spending is also very low. It's 1.5% of GDP or 8.3% of total government health expenditure. So as a percentage of total government health expenditure, it's not too bad, but as a percentage of GDP, it's quite low. Out-of-pocket expenditure, 50% is really high. That even though it's always stated that most of the out-of-pocket expenditure is incurred by the richer population of Sri Lanka, I don't think that 100% is not true. So some amount is significant, but there's still some amount of poorer people also spending out of their pocket. And health insurance is very, very marginal, only 2.4%. That need not be a big factor. Tax financing can also achieve universal health coverage, but it's just a statistic that I want to share here. Here you look at current health expenditure, you see Sri Lanka is on the lower end compared with so many other countries that are presented here. Here you selected country health expenditure, again Sri Lanka is on the lower end as a per capita even on purchasing power parity. Then here you have selected country comparisons of public-private share, and Sri Lanka you can see private and public is roughly equal. There are countries where public is hugely much higher than private, and there are other countries where the private is even much higher, 74% in Bangladesh, 75% in India, so on and so on. So here we have a selected country out-of-pocket expenditure. Sri Lanka is somewhere in the middle, but still I would say this 38% is low. This is an old data. I think now out-of-pocket expenditure is almost 50%. So what are the challenges that Sri Lanka is facing? Number one, there is insufficient resources for health services. I think there is universal agreement on this. Almost nobody will object to this statement. There are inefficiencies. There are allocative inefficiencies. There are technical inefficiencies. And again, I think in most of the discussions that we've had, and Dr. Sridharan mentioned that I was working on this for the last 5-6 months, supported by WHO. And basically, nobody disagrees on this statement. Everybody agrees there are inefficiencies. There are also inequities. Inequities in Sri Lanka are not as bad as inequities, let's say, in India or Bangladesh or some other countries of the region. But still, they are there, and they need to be addressed. There need to further reduce catastrophic and impoverishing health expenditure. Out-of-pocket is very high. Public financial management issues are there, starting with budgeting, but also in allocation and then how they are spent and how the auditing and accounting is done, etc. Human resource for health issues, they are huge. They are universally recognized in Sri Lanka. Everybody agrees that there are issues to be addressed. And there are need for greater synergies between private and public actors. Currently in Sri Lanka, there is very little cooperation between public and private actors. There is some, but there is not enough. So this needs to be improved. So here, this exercise was started sometime in March, and this exercise of health financing strategy development was through a national discourse on health financing reform options for universal health coverage. The process was to develop a health financing strategy and policy. And the overall goal was universal health coverage for all Sri Lankans. And the objective was to increase the access, utilization, coverage of essential health services, to improve the quality of care, and to enhance financial protection. So then, based on the exercise, basically, let me go back to this because the process was here. Broad-based stakeholder consultations were conducted, because that slide should be actually coming after this slide. Beginning with the workshop, this was conducted by Ministry of Health with WHO support in March 2023. There was a steering committee set up by Ministry of Health, chaired by the Secretary, that has been guiding the process. There have been ideas, almost 65 ideas emerged from the workshop. They were rated by the stakeholders, and the previous slide, which I will show later, is the rating scores based on importance of the idea, based on the impact of the idea that would have on universal health coverage, and the implementability of the idea. The 3 I's: importance, impact, and implementability. 8 subcommittees were set up to consider these ideas. They are categorized by 6 strategic areas that the Ministry of Health had identified. These subcommittees met in July, and then a health financing strategic directions paper has been prepared by the Ministry of Health and submitted to the Treasury. A retreat of the key stakeholders is being planned for October, I thought, but now it's going to be November, to take the dialogue forward with the view to developing a health financing policy. Let me see now. Here is the rating exercise scores. The point here to see is that on all 3 factors, importance, impact, and implementability, financial protection seems to be the highest rated area. So that means everybody feels that financial protection of the poor is the most important thing to achieve. Now, by the way, all these areas are very important. The least important was even 7.7, so out of a score of 10. So it's not that it's not important, but relatively speaking, financial protection was considered more important, and then effectiveness, efficiency, and equity, risk and resource pooling, these are considered very, very important. Top 3 are these 3 areas. Okay, so this is the process I already talked about. So what are the key ideas? The key ideas are to increase the public expenditure on health, to improve the pooling of risks and resources. Everybody understands that there is quite a bit of pooling that's taking place, because after all, Ministry of Health is financing most of the bulk of this healthcare here in Sri Lanka, especially curative care, especially inpatient curative care. Most of it is provided and financed by the government, and that is a mechanism of pooling risks and resources. It's a fairly strong mechanism. It's well legitimately accepted. Insurance is not the only mechanism of pooling, right? So tax-based financing is being followed, but we need to improve the way it is being pooled, improve the way that it is being allocated. So strategic purchasing of selected services by the government on behalf of the poor and vulnerable population. This is a very, very important and strong suggestion that emerged from the process. Strengthening governance and accountability came out as a very, very important area as well. consider the separation of financing and purchasing in order to achieve this strengthening of governance. Minimizing system loss and inefficiencies. Many examples were given, but one of the common examples that was given was the fact that people are bypassing cheaper and lower levels of healthcare, going to the more expensive and higher levels of healthcare directly to tertiary care, for example. So that is one. There are several other system loss. Procurement area was identified as a big area of inefficiency. So there are many other areas that I will not go into details here. But another area that suggestion that came out was results-based financing, performance-linked budgeting. Again, this kind of thing will improve the accountability, they improve the performance, because if you link the incentives to results, then you can actually see better results. And hospital autonomy was seen as one possibility to achieve, so that local level decision making can be taken, can be promoted, can make the decisions more locally relevant, locally appropriate to the accountability and the need of the local area. So hospital autonomy was considered as one of the ways that could be. That means the hospital directors and the hospital management will have greater decision-making power. Defining and costing essential package was considered to be an important activity that has to be completed. Establishing an appropriate institutional mechanism, which I already mentioned. Introducing a digitized automated system. This also came as a strong suggestion that currently a lot of these systems are even the systems that are currently digitized, they are disintegrated. They are not all integrated into one system. So in some way, there has to be more efficiency introduced, and I believe that Ministry of Health is working on this. There is a separate department or unit that is focused on this to automate the systems of procurement, patient records, financial audits, and so on. So what are the next steps? I think this is my last slide. So before what Sri Lanka needs to do, we need to conduct a thorough health expenditure review and the national health accounts system. So our national health account. Health expenditure review should not be only public health expenditure. We should do public and private health expenditure, which essentially becomes national health accounts. So this is sort of being done in Sri Lanka in the past, but most recent one that was done is I think 2018. And definitely there's a lot that has changed since then, especially given COVID and given this financial crisis. So we need to have the most updated information on this. So this is a very important sort of prerequisite. We have to revisit the budget process. Currently, the budget process is all line item budgeting, which is sort of incremental, marginally increased every year kind of thing, which is not really based on need. And it's not based on epidemiological need. It's also not based on clinical need. So we have to look at this process and see in the same way, see how we can do some sort of results-based financing or performance-linked incentives and so on. We have to review the composition of out-of-pocket expenses. I kept hearing throughout the discussion that most of the out-of-pocket expenditures are done by richer people. The problem is out-of-pocket expenditure data does not capture the foregone care. Poor people who spend out of pocket is one thing. There are some poor people or middle class or lower middle class people also spending out of pocket. But there are a lot of healthcare that they may not even access because it is too expensive and they cannot afford it. That doesn't come into the data. The data only captures what is spent. What is not spent because they cannot afford, and therefore they could not, that is what the extent of foregone care. So that doesn't capture in this data. So I think that this whole idea that out-of-pocket expenditure in Sri Lanka, it's not such a big issue because it's being spent by the people who are better off. I don't buy that idea. Yes, it is true to some extent, but it's not the full story. Finalizing a clearly defined and costed benefit package has to be guaranteed for every citizen. But now we have to understand what is this benefit package. It does not mean free health care by the government. This benefit package means it's the benefit that everybody should have access to, regardless of who is paying and who is financing and all that. I must have access to it. The government's job is to ensure access to it and make sure that the payment is according to their need. So everybody has to contribute. There is no such thing as free care. Free is not, nothing is free, right? Because somebody has to pay for it. How do you pay for it? Do you pay for it only through the taxes? Do you add a health surcharge? Do you pay for it through private insurance? So all these kind of complicated, complex mechanisms have to be considered. But first of all, we need to decide what is the package of health services to which every citizen shall have a right. It's a right. It is not a privilege. It is not something that somebody can have, somebody might have. No, everybody must have that right. Designing and developing health institutional mechanisms, I have said this many times because it's very, very critical. Without proper institutional mechanisms, nothing is going to work. Conducting the technical work needed for strategic purchasing. Now, I have mentioned this strategic purchasing a few times. A lot of people may not understand what it is because very often when I talk about purchasing, people think of purchasing medical equipment, people think of purchasing drugs, people think of purchasing that currently they do in the health sector. That's not what we mean by strategic purchasing. What we mean by strategic purchasing is government purchasing the healthcare services from the private sector on behalf of the poor people. Obviously, not all services, because many services are currently provided for free anyway by the government, but there may be some services which are needed to be strategically selected and the government needs to decide. But this is a technical area and there's a lot of issues to be considered here. So there has to be a design and pilot testing of this, because how it will work, we need to test it and then make sure that it's implemented. It's completely new for Sri Lanka, so we can't introduce it whole lock, stock and barrel just like that, throwing away the current system. No, that's not the idea. The idea is let's test out which areas need to be purchased, which services need to be purchased, and for whom, on what behalf of whom, and how to manage it, etc. So there's a lot of issues that need to be, technical work needs to be conducted. Leveraging non-state actors. Now, this non-state actors leveraging is not only for providing. Now, the private sector is providing what is privately financed, public sector is providing what is publicly financed. There is very little crossover. There is some crossover, but very little. So, what we are talking about is not only finance, not only provision, but also for financing, we can leverage the non-state actors or private actors. Deciding on developing provider payment. Now, I did not go into details on this, but each method of provider payment has its own incentives and disincentives that come with it. For example, if you pay salaries are paid based on time. I get a certain salary per month or per week or per day, regardless of how much I work, regardless of how I work. So salaries, the incentive is not for effective and efficient service of delivery. Salaries simply, it's really not the best way if you want to increase. So that's why we talk about results-based financing and performance-linked incentives. But then we talk about fee for service. Fee for service means per X-ray, I will pay X amount. Per surgery or per delivery, I pay X amount. So that is fee per service, per item of service. Now the problem with that is it incentivizes more services to be provided. So maybe even unnecessary services, unnecessary investigations, unnecessary X-rays, unnecessary procedures may be performed. So that has its own problems of plus and minus. Similarly, there is another thing called capitation. Capitation is usually used for GP services or especially primary care services, where we say that per head, capit means head, capitation means per head or per person that you care for, you provide for 1 year X amount of money. This is tried, for example, in NHS in the UK, where the GP is provided a fixed amount of money per person that he or she covers per year. Now, for that amount, they have to provide a package of services, regardless of how many times that person visits, regardless of how many medications or what consultations that person has to receive. So, that's a fixed amount per person per year, so per capita. So, that has again its plus and minus, but that's very suitable generally for sort of gatekeeping functions, the GP functions, general practitioner who provide as a gatekeeper to go to specialist services. Now, in order for it to work in Sri Lanka, we need to have a good referral system. Otherwise, it will not work, because the GP has to then, in UK, you cannot go to a specialist before going through a GP. In Sri Lanka, that is not the case. You go directly to an orthopedic surgeon. So that has to be looked at, and unless the referral system is built, this will not work. Then the last one is the DRG, or diagnostic related groupings, where a fixed amount is negotiated between the hospitals. Generally, it is used for inpatient care, for expensive procedures. So for example, for a 3rd degree burn, I will pay X amount, regardless of how long you keep the patient, whatever treatment. So based on diagnosis, it's not based on the treatment, it's called diagnostic related groupings. This was introduced in the 90s or late 80s in the US as a way of cost containment measures, because otherwise people started producing unnecessary care and then keeping patients longer than required in the inpatient which is also one of the inefficiencies that was identified in Sri Lanka, that people sometimes are kept admitted unnecessarily and then kept for longer than required. So these kind of inefficiencies can be reduced if we say that we are going to pay only so much amount for a certain diagnosis of certain severity or certain seriousness. That means regardless of how long you keep them or how many x-rays you take or what investigations you do for the person, we are going to get only X amount. The hospital is going to get only that amount. So that is a way of cost containment. Again, it has its plus and minus. So we have to come up with a mix of provider payment mechanisms. Lastly, how to whether or not social health insurance schemes. Now, this is whether it is useful for Sri Lanka is a debatable point. Feasibility is also a debatable point. There are issues there in terms of feasibility, because in order to have an insurance mechanism, we need to have a way of collecting the premiums. Particularly because in Sri Lanka, a lot of the bulk of the Sri Lankan labor force is in the informal sector. How are we going to collect premiums from the informal sector? So that is a bigger challenge. And then question is, why do you even need it? If you have a tax-based pooling mechanism that works fairly well, do you really need an insurance scheme? But I know that there is a fairly strong sort of lobby which is pushing for this in Sri Lanka. And so we did not want to sort of completely rule it out or close the subject. So we put it as exploring the feasibility and usefulness of this. But it's not something that WHO is recommending for Sri Lanka, because based on global experience, there are some sort of challenges faced, let me put it that way, in this particular idea. Okay, so that's the last point. Here I'm just sharing with you some of the WHO reports as reference. One is on World Health Report 2010, which is focused on health system financing, and the other one is on research for universal health coverage. There are others, obviously, but these are something which I found somewhat useful. So with that, I would like to thank everybody for listening, and certainly I'm happy to take any questions. I hope that I did not speak too quickly. Sometimes I have a tendency to talk too fast. Thank you.
Okay, thank you, Professor Dr. Sundararajan Gopalan, for enlightening on sustainable financing, planning the way forward in relation to Sri Lankan context, and we have worked together in several occasions. So now I have finished by 12:10. Can I ask organizers to give me 10 more minutes? It's okay? Okay, thank you. So kind of you. So this is a panel discussion. So first I'll start start with a question to Dr. Krishna Reddy and Professor Tan. Dr. Reddy, you spoke about these health needs, when, where, how and what. And Sri Lanka provides free health service. So how to define what to provide? Can we go even to the high-end surgeries and cosmetic surgeries? That's my question to you. And Professor Tan, now in presentation you told about in 2025, 25% of your population will be elderly, and Sri Lanka in 35. So we have 10 years more. Can we learn? Can we learn from your preparation to how to address the elderly population? Okay, so let Professor start. Yes.
Yeah, I mean the question of what extent of services the government can provide. From a patient perspective, for them everything is important. But to make it possible, we need to look at from a population health management perspective. I think what was mentioned also, the investment on promotive care and the preventive care. So whatever you save from that should be able to afford those who require advanced care. Yeah. Because you can't, I mean, as a patient, you can't deny somebody if they feel that they require that advanced care. If somebody has end-stage renal disease, they want a renal transplantation, we cannot decline that. But to make it possible, I mean, that is where the concept of the value-based care is coming in. That means at an overall population level, can you still make it possible to give the best outcomes with a optimized cost structure. So that's where the investment has to be, like in earlier times, it was purely hospital-based care. Now there is a huge talk on primary health care, but both are important. Both are important and continuity of care important. From a given country perspective, I mean, because the needs are unlimited, but the resources are limited. That's where what Sundararajan has mentioned in terms of priority setting. How do we set the priorities if we have only this much money that we have? So that's where the priority automatically is well tested. That is, promotion takes the first priority. The disease prevention takes second priority, the primary prevention. The secondary prevention, which aims at preventing hospitalizations, preventing major adverse effects. So these are at least, so that is what I think that every country has to decide based on the resources available and the demand that is there as to what it should prioritize. And this prioritization should include a dialogue with the people who are going to be benefited. Because it should not be top-down prioritization. The people also should spell out what actually they require from prioritizing. Yeah. So these are some of, it's complex and very challenging. Very challenging. But this has been the approach, I think, some of the countries which have been, for example, if you look at the Thai health system, or even, of course, Singapore is a small place, but the Thai health system, for the same level of GDP expenditure, the total health expenditure of 3.5% or something, I mean, their health indicators are on par with US. So that means because they invested in primary health care, they invested in promoting health care. At the same time, they're not denying advanced care. So this is one of the approach to making a balanced approach to patient requirement, because from patient perspective, for them, curative care is the top priority. For them, they won't understand promotive care and preventive care. But when they fall ill, they want something to be done. Yes. So that's how we need to balance it. Yeah.
Thank you very much. I asked only from Dr. Krishna Reddy and Professor Tan, because Dr. Sundar Gopalan and Professor Nalina Besekar, I have the liberty to talk to them anytime, even over the phone at 10 o'clock in the evening. Okay, Professor Tan, over to you.
I believe, if I can rephrase the question you're asking about what Singapore is doing to address a rapidly aging society. So one of the first things we do is that we try to learn from other people, like Japan, right? I think that we have got, maybe I want to look at 3 levels that we are trying to address this. One is at the level of national policy. 2 is the social structure. And last but not least, what the health system is doing. The aging population in Singapore, it wasn't just the number, but it's the speed at which we are getting at. In 2013, 1 out of 7 Singaporeans, working Singaporeans, are above 65. So 1 above 65 are supported by 7.5 below 65 working age. By 2017, 2018, the number has reduced to 5.5. And very soon we believe that 35 or to 2035, we're probably looking at 1 in 3. Now, that means that the disease, the burden to the society of caring for the elderly in all aspects of that care is going to be borne by relatively fewer and fewer number of actively working population. So one of those things that Singapore government has been doing is increasing the retirement age. It has gone from 60 to 62. Recently, it has been raised to about 67. I believe by the time I reach there, it might be 70. So I'm always chasing for the retirement age. Not that I'm looking forward to it all that much, but truth be told, we have been trying to raise the retirement age so that you have a larger band of working population. The other thing that Singapore has done is a little bit radical, is we believe that the children has an obligation to care for their parents. So it's a joint care concept. Yes, the government will want to be able to care for the elderly, but the children has to do their part. And maybe about a decade ago, 10 years ago, they even implemented this law that children, your parents can sue you if you do not care for them. Now, since the law was enacted, we have heard of very few cases that this happens, but the truth of the matter is they put an OB marker out there that it is a joint responsibility along with the government. The third thing is that increasingly we are providing more healthcare subsidy to the elderly. And that's kind of what we are doing now, starting with what we call the Merdeka, which each successive generation, they have a name for this, a pioneer generation, Merdeka generation. In all of this, there's a tiered, enhanced healthcare coverage scheme, which is strongest and best at the pioneer generation because this address people who are currently at the 70s, and then we move to Merdeka, the people that are now between 60s to 70, a slightly reduced coverage, but still better than the general population. And I think the fundamental principle of that is that the society has moved quite rapidly in the last 50 years, that the younger people, my generation and all, we begin to pay more attention about own healthcare, and we buy insurance to cover our own healthcare. But my parents' generation, they definitely didn't. So the nation is kind of making this provision to help them. So, but on the social side, which is also very important, more and more, as you know, Singapore, 85% of Singaporeans live in what we call housing development board flats. These are like council flats. They are good standards. They are clean. In these flats, they are building social clubs. They call it senior citizen club to encourage citizens within that community to be able to participate in social activities, remain engaged, a little bit like the old village spirit, kampong spirit, but reenacted in the modern world. The other thing that they have done is some zones now, they are test bedding this, where they are building neighborhoods that are elderly friendly. And this is in anticipation of potentially a higher prevalence of elderly. They may have dementia, but living in a community, and we want them to be able to live in a community meaningfully and still interact with the social space. So the neighborhood are color-coded so that the elderly can remember where they go and how to go home. And various facilities to make it easy for them to navigate from their home to the grocery store to wherever facilities that they need to go. And then we come to the health system. At that level of health system, I think I addressed that in my talk about how do we do disease prevention, looking at the elderly population, and various measures put in place to allow us to do that. This is what we call the at-risk population. The hospital environment itself, we are looking at elderly-friendly design from, labeling, directories, etc., to facilitating elderly by having concierge services so that elderly walk into the hospital are able to get the kind of care that they want to. I think that's sort of in that three parts: national policy, social fabric of Singapore, and also in the health system, have to work synergistically together to make this happen. Thanks.
Thank you, Professor Tan, for that comprehensive explanation. And I will ask Chair and Co-Chair, you want to ask any Chair Academic Committee?
I think better to
yeah.
So to open the floor for the audience.
Audience, any questions? No questions? So clear, or you're hungry? Okay, we'll go to the chair academic committee. No, panel discussion attended. No. Question, panel discussion.
Thank you, Dr. Sridharan. Now, actually, indeed, a very interactive session, informative session. If there are no questions, we can go to the other agenda item.
Chair, co-chair, you have any question? No problem. Issues. Okay. So, if there is, yeah.
Thank you, Dr. Sridharan. Actually, our moderator, Dr. Sridharan, made our job easy. So then, chairs and co-chairs job. But anyway, that as a college president and also the for the chair and co-chair, I would like to actually make some comments. And anyway, that first of all, actually, we have to convey our sincere thanks, not as the thanking speech, but anyway, that really appreciate all the presenters, all the speakers and the panelists. So then actually they are coming from faraway places, Singapore, India, and also that even with the weekend leisure, actually without having the leisure, so then Dr. Gopalan is joining with us. Anyway, first actually Dr. Reddy gave a very good presentation actually regarding with all the details regarding the resilience. But the most important thing actually he highlighted the evaluation. So then for the tool for evaluation. So anyhow actually we have to assess the system, how much actually we are ready to actually to be a resilient system. So then the tool other way around actually it will be a guide for us. So anyhow, actually, while assessing, so we can actually identify the gaps and we prepared for the fulfilling the gaps. And it will be worthwhile to do a self-evaluation. And then actually Professor Nalin discussed with us regarding the good governance. At the moment also that even our treasurer, he couldn't actually participate for this. Those are actually attending for the preparing the answers for the COPA and the audit committees. Okay, so then and that's how actually that so much important this topic, the resilience, the system, health system, sustainable financing, and good governance. So then not only actually taking preventive measures for the good governance, but also we have to market what we have done, what our dedication is, what our commitment is. So then we have to market and we have to express to the public how much actually we have dedicated so far. And anyway, for the other parties also, other side also, there should be appreciation for what we have done. Okay? Thank you. So then Professor Professor Tang, sorry. So actually we highlighted many issues. So then it's an eye-opening presentation with a very informative presentation for eye-opening for our members. And so we have done, we have expressed. So then there are 240,000 shortages in health workforce. If you are willing, actually we can, within few years, actually we can provide that, fulfill the shortage. So then, anyway, that so then you actually identified the strategies from tertiary care to primary health care. So then in our country also, then we actually have a very good primary health care system, but anyway that we want to get it more strengthened and expanding into the other sectors also, that strengthening that actually with the family care clinics and everything. But some specialties are opposing to with the Ministry of Health to take such actions. But anyway, that it will be actually, we have taken the decision, it will be taken forward anyhow. So then Dr. Gopalan, so then actually that you gave a very informative presentations. So then with the very details to our members and young leaders. So then thank you so much actually. And also I request our young leaders not to take actually, not to listen, just listen and take into your heart and take it to actually put into your action in your career, in your professional works. Thank you.
Yeah, thank you very much. First of all, I would like to thank all 4 speakers attending this prestigious pre-congress session and giving the valuable thoughts and inputs for our whole fraternity. As a chair, I think myself and the co-chair, Dr. Panapitiya, Dr. Sridharan, helped us a lot doing the both. So our workload has been reduced. So I think Professor Nalini is not a stranger to us. He is actually my teacher. And I think rest also now you all are not strange for us. And what you have taught is, I think, practically we are practicing right now. Not by and large, but all these administrators, young administrators, they are practicing because we are really struggling with the economic meltdown and we are struggling to sustain the system. So I hope the young administrators, they got the message. I saw most of them on the phones, but I think some of them got the message very clearly. So rather than spending more time, I am inviting Dr. Sudat. The next agenda item is distribution of token of appreciation and certificate. Over to comparing.
Now it's a distribution of tokens and tokens of appreciation certificates. Yes.
Thank you, sir. With that, we conclude the panel discussion. On behalf of the distinguished gathering, we would like to bestow our sincere gratitude to the eminent panelists, chairpersons, and the moderator for convening a highly technical and fruitful discussion. We are confident that the lectures and the discussions held here today have given us all a wealth of new information. Thank you.
As a gesture of gratitude to the honorable resource persons of the technical session, we have some tokens of appreciation to be presented. We are delighted to call upon the chairperson, Dr. Asela Gunawardana, the co-chair, Dr. Lal Panapitiya, to give away the tokens of appreciation and certificates to our guest speakers. I kindly invite Dr. Krishna Reddy, Professor Nalin Abesekara, and Professor Tan Hien Koon to accept our presentations. Firstly, Dr. Krishna Reddy Nallamalai. Secondly, followed by the token of appreciation will be given to Professor Nalin Abesekara. And also, Professor Tan Hien Koon will be receiving our presentation.
Thank you. Next, the Director General of Health Services, Dr. Asela Gunadana, will receive token of appreciation from Dr. Lal Panapitia. Then it's time for the presentation to Dr. Lal Panapitia. To do the honors, we would like to invite Dr. Neelamani Hemagigana. Madam, could you please join us on stage to do the honors? Madam, stay on stage for the next presentation. Dr. Sudat Dharmaratna, the chairperson of the Academic Committee of the College of Medical Administration. Please come and accept our token of appreciation. Thank you, madam. Thank you, madam. Rani, madam. Next, to present the token of appreciation to the moderator of the head table, Dr. Sridharan, we'll call upon our past president of the college, Dr. Ms. Rani Fernando. Madam, if you could please join us here to do the presentation. Dr. Sridharan will accept the token of appreciation from at this moment. Before we proceed with the presentation, we'd like to thank Dr. Sundararajan Gopalan, who joined us virtually to share a tincture of his vast knowledge and experience with us. Thank you, sir, for your contribution at this occasion. And we hope to meet you when you come visit Sri Lanka in the future and share a moment with you. So if we proceed with the presentations now.
Next, we have token of appreciation for the event coordinators. For the presentation, I cordially invite Dr. Lal Panapitia to the stage, please. Firstly, I will kindly invite Dr. Uppuli Vijayamana to the stage to get our presentation. Next, Dr. Gauri Sanketa. And I also invite Dr. Nanil Premadas. Dr. Nalin Premadas. Thank you, sir, and thank you all. Ladies and gentlemen, since we have come to the end of the pre-Congress session, it's our great pleasure to invite Dr. Sudha Dharmaratne, Chairperson, Academic Committee of the College of Medical Administrators and the Deputy Director General of Health Laboratory Services to deliver the vote of thanks.
Dr. Lal Panapitiya, the President of the College, Dr. Asela Gunawardana, immediate past presidents, Dr. Nilamani Hevagigana, Dr. Rani Fernando, the past presidents, members of the council, members of the college, respected guest speakers and invitees, ministry officials, provincial directors of health services, regional directors, medical superintendents, senior registrars, and MSc trainees in medical administration, ladies and gentlemen. As the chairperson of the academic committee of the college, it is with immense pleasure I am proposing vote of thanks in this occasion. After completing several pre-Congress sessions during the last 3 months. Firstly, I would like to thank our special guest, Dr. Alaka Singh, WHO representative to Sri Lanka, who had to leave early due to her busy schedules, for taking time to grace this occasion. Also, I express my sincere appreciation to Mrs. Vijay Rao, Director Singh Health, Singapore, for his enormous support and gracious presence here today with us. On behalf of the college, I pay my sincere gratitude to our speakers today, Dr. Krishna Reddy Nalamala, Professor Nalina Besekara, Dr. Sundarajan Gopalan, Professor Tan Hyun Koon, for their informative and inspiring speeches. And also, your presents are very delightful. And this presentation imparted very good insight in relation to their selected topics. Dr. Reddy, Professor Tan, thank you very much for coming all the way from your countries to enlighten this session. Dr. Asela Gunawardana, Director General of Health Services and the immediate past president of the college, thank you very much, sir, for chairing this event and being with us despite your numerous official commitments. My heartfelt gratitude goes to Dr. Lal Panapitiya, President of the college, not only for co-chairing this event, but also being a tower of strength and inspiration given by you to conduct all college activities this year very successfully. Dr. Samidhi Samarakon, our able Secretary of the College of Medical Administrators, thank you very much for the immense support given by you for organizing all academic activities, including this pre-Congress session. I must thank Dr. Sathasivam Sridharan for moderating this event and for being the lead to organize this pre-Congress session by coordinating with the local and overseas faculties with the assigned members. I must also thank Professor Amala De Silva, is a teacher and a trainer for the MSc and Medical Admission training programs, for your gracious presence today. And you have given a lot of contribution to development of medical administration. Thank you very much, madam. And council members and the office bearers of CMSL, thank you very much for taking part in this important event and giving your fullest support to make it a success. I take this opportunity to express my sincere appreciation to the convener of the academic committee, Dr. Dinesh Kokgalage, and the academic committee members and the organizing committees in this pre-Congress session. I'm not going to name each and every one. There are a very talented bunch of medical administrators in this audience. They are backed by your very exceptional organizing skills. That is why we make this event a success. We are really proud of you and thanking you for your enormous support for making this event a reality. I thank Dr. Bhamini and Dr. Indri's young budding administrators for excellent comparing. I would be failing in my duty if I do not thank Sri Lanka Chamber of Pharmaceutical Industry for their exclusive sponsorship for this pre-Congress session. A special thanks goes to the management of Golf Face Hotel and the event manager who played a key role behind this event. Ladies and gentlemen, I would like to thank each and every one of you for being here today and paying undivided attention to the pre-Congress proceedings. Finally, I look forward to having a glorious and glamorous inauguration ceremony today evening. So let me conclude the vote of thanks and this session by inviting you to enjoy your lunch, which is arranged outside the hall. I wish you a pleasant day ahead and thank you very much for your kind attention.
Thank you, sir. With that, we have successfully concluded the pre-Congress session for the 30th Annual Scientific Sessions of the College of Medical Administrators. We hope it had been a pleasant experience for you altogether. Thank you for your cooperation and participation. Before we wind up, let me remind you to join us in the evening for the inauguration ceremony.
Wrapping up today's session, it brings me a great pleasure to extend an invitation to each and every one of you to join us for a delightful lunch at the buffet area. Thank you.
Thank you.